Good morning and welcome to the 20th meeting in 2013 of the Health and Sport Committee. As usual, can I remind all of those present to switch off mobile phones and Blackberries, as they can often interfere with the sound system. People in the public gallery may also notice that some members and officials are using iPads, and that this is instead of hard copies of their committee papers. The first item on the agenda this morning is we need to take a decision on item 7 and to take item 7 in private, which is consideration of a draft report on access to new medicines. I don't think so. No, it's a decision to take on our work programme. So can I have agreement from the committee that we take item 7 in private, please? Agreed. Thank you. We now move to agenda item number 2, which is to take evidence on an affirmative instrument, which is the Public Services Reform, Functions of Common Services Agency for Scotland, Health Service Scotland Order 2013 draft. Hopefully I'll not need to say that again. And can I welcome Michael Matheson, Minister for Public Health. Welcome, Minister. He's accompanied by Stuart Aitken, Policy Officer, Director for Finance and E-Health and Pharmaceuticals, and John Paterson, Deputy Director, Legal Directorate, Scottish Government. Welcome to you all. And I invite at this point the Minister to make some opening remarks.
Thank you, Convener, and good morning. Thank you for the opportunity to attend this morning's committee meeting to speak about and in support of this draft order. For the avoidance of doubt, although the draft order refers to the functions of the Common Service Agency, I will refer to the organisation as it's more commonly known, which is NHS National Services Scotland, or NSS. NSS is Scotland's largest shared service body, supporting Scotland's health by delivering shared services and expertise that help other organisations to work more efficiently and to save money. NSS provide national strategic support services and expert advice to all of NHS Scotland, and also plays an active and crucial role in the delivery of effective healthcare to patients and the public. Current legislation dictates that while NSS may provide goods and services to NHS bodies in Scotland generally, it has the power but not the function of providing a limited range of goods and services to other public bodies, and then only to a limited range of public bodies. It is considered that this acts as a barrier to NSS being as efficient and productive as it might otherwise be, and as a barrier to the Scottish public bodies being as efficient and productive as they might be. It therefore follows that it prevents the public sector in Scotland working as efficiently and as productively as it might be. The purpose of this Public Service Reform Order is to enable NSS to move from being a provider of shared services to NHS bodies to being a provider of shared services to Scottish public bodies generally. NSS has a strong reputation for delivering shared services and is looked upon with high regard across the public sector. The agency has systems in place to ensure that standards are maintained across its full range of services, and these have operated efficiently and effectively for a number of years in the context of the wide range of public bodies to which the agency already provides services. It's clear that there are opportunities for NSS to offer services such as legal, procurement, counter-fraud and IT support to the wider public sector. What should be made clear is that the order makes enabling provision and does not impose any obligation on relevant bodies to take services from NSS. Nevertheless, it's hoped that this will facilitate greater use of shared services across the public sector in Scotland. The overarching purpose of this order is to remove obstacles to the efficiency and productivity of NSS and other public bodies. And I'm happy to answer any questions committee members may have.
Thank you. The Do any members have questions for the Minister? Richard Lyle.
Morning, Minister. Can you tell me what other range of bodies that have given me a flavour of who else we would be looking to supply goods and services to from NSS?
It would principally be bodies such as local authorities and looking to provide them with support and assistance in delivering services.
Just the 32 councils in Scotland?
Pardon?
Just the 32 councils in Scotland?
Not exclusively. It could also be non-departmental public bodies as well. So, but principally a combination of the NDPBs and the local authorities.
Okay, thank you.
Yep. Nanette Millen.
Is this a sort of reciprocal arrangement? Does the same happen in reverse? Can local authorities procure services from the health service in the same sort of way?
The purpose behind this is obviously NSS already provides services to NHS Scotland, but they don't have the function to be able to provide it to bodies such as local authorities or to non-departmental public bodies. What this order will do is we'll provide them with the function to be able to do so. But the whole issue around shared services is a matter that has to be done on the basis of cooperation and mutuality, so it's got to be a shared interest. So,
yes, it was the...
Yeah, so there's no... Yeah, so NSS is a national body which delivers services at the request of those who ask them to deliver a particular service for them.
Okay.
Are there any other questions? No? Then we move then to agenda item number 3, which is the formal debate on the affirmative SSI on which we have just taken evidence from the Minister. I remind members in this debate, this is a debate, so no further questions should be put to the Minister at this time. And obviously, can I remind the officials that they are no longer able to speak in this part of which is now a debate. I invite the Minister to move S4M 6995, which is been laid before us and previously referred to.
Moved.
Thank you. I invite members who wish to participate in the debate. Do any members wish to participate in the debate? No? Then I don't know how you possibly sum up, but you have the opportunity, Minister, to make some remarks if you wish. If not, we put the question.
I'll take the silence as a note of content.
Yeah, thank you. We therefore put the question on S4M 6995, laid out before us, previously referred to. Do we agree the question, the motion? We agreed. Thank you very much. Can I thank the Minister and his officials for their attendance this morning, and we temporarily suspend until they vacate. Thank you very much. To agenda item number 4, which is consideration of 4 negative SSIs laid before us. Is it required for the record that I read these through, or
Maybe just do the titles, don't we? Just
Right, I'll just take the titles of the instruments, the negative SSIs laid before us, which is the Glasgow Commonwealth Games, National Health Service Superannuation Scheme, Pension Scheme, National Health Service Superannuation Scheme, and National Health Service Free Prescriptions and Charges, Drugs and Appliances. It's laid out before you. There has been no motion to annul these instruments, and the Delegate Powers and Law Reform Committee, what is that?
Subledge, it's changed its name.
Oh, it's a Subledge, it's changed its name, that took me by surprise. And Law Reform Committee has not drawn the attention of the Parliament to any of them. Does any member object to me putting the questions on the negative SSIs en bloc? In that case, then, the question is that on the 4 negative SSIs set out on the agenda, the committee has no recommendations to make. Are we all agreed? Agreed. That is agreed, thank you. And we now move quickly to agenda item number 5, which is our annual scrutiny of NHS board budgets. And can I welcome to the committee Craig Marriott, Director of Finance, NHS Dumfries and Galloway, Paul James, Executive Director and Director of Finance, NHS Greater Glasgow and Clyde, and Fiona Ramsey, Director of Finance and Planning, NHS Forth Valley, and Jerry O'Brien, Director of Finance, NHS Orkney. Thank you very much for your attendance here this morning, and welcome. In the interest of time, I think I'm going directly to questions, and my first question is from Nanette Millen.
Thank you, Convener. Good morning. I'm quite interested in service development, and authorities were asked questions to feedback on service development, and by and large the responses that were received, but they did vary quite a lot, with examples of new services being introduced and obviously services that boards would like to introduce. There was very few comment about, or very few examples of services being withdrawn. So I wanted to ask, really, are services routinely evaluated to see if they are effective and continue to be effective? And are there any examples where services have been found to be ineffective? And really, why are services that are found to be ineffective not withdrawn across the board? I mean, it would have been I'd be interested to hear your comments on that.
Mr. Martin.
Can I maybe kick this one off? We have a process within Dumfries and Galloway which is called making difficult decisions, and that's where we've got a kind of clear process where we review the services and how the services are provided. We'll look at the kind of ethical background, we'll look at the return in terms of the investment from that service, and we'll look at the research background. And over the past few years we've used that on a number of occasions to review services. In the past year we used it for homeopathy. In the back of that review, which takes into account stakeholders, all of the professionals across the organisations and users, we decided to restrict the ability of new homeopathy patients to the service. Not a particularly large reduction. I mean, it's only kind of £10,000 across Dumfries and Galloway, but I suppose it's just been clear across our organisation that we continue to review the efficacy of services and how they're provided. In previous years we've used that framework to review other services. Acupuncture was one we reviewed in the previous year as well, and we decided to restrict the use of that specific treatment.
James.
Could I just add that if you look at our financial plan, you'll see that the large majority of our cash releasing savings have come from prescribing in 13-14. Therefore, we've had to make very little impact on our frontline services in acute and partnerships, and the cash releasing savings that we're looking for are 9 million from those, which are relatively small compared to the previous year. So I would say in terms of service reductions, no, we haven't had any major service reductions, but we have pointed out in our submission that we have redirected some of the expenditure in certain areas. So we gave an example under the preventative spending of tobacco that we were redirecting towards different areas. So I can't give you the details of where we've actually, within the tobacco initiative, reduced spend in order to increase spend in other areas, but effectively there's been a rebalancing of priorities.
I think within Orkney, probably the area where we're more at most advanced stages is within our local alcohol and drugs partnership. We're over the last couple of years, probably led by our Director of Public Health. We've developed a commissioning model where we actually now have a formal process where those organisations, which is a combination of health, local authority and third sector organisations who receive the alcohol and drugs funding, are asked to submit 6 monthly reports on outcomes achieved from each of those services. So they submit one at the end of September, and then they submit a year-end one. And those reports are used by the strategy group, of which health, local authority, police and third sector colleagues are all members. We then evaluate those services based on that, and that informs future years' commissioning decisions. So that's probably where we are most advanced within NHS Orkney for looking at that. So, and we have definitely moved funding around, as Paul has said, and the services which have previously been funded through ADP, which we've said that's we can actually see more effective use of the ADP money.
In Forth Valley, we've got very similar processes, a strategic planning group that reviews service change, and I think our focus has been more on service redesign, so it's making best use of the resource within particular areas and moving the resource around to make sure you've got maximum impact. Similarly, any proposals that go through that route have to go through an evaluation process, so a year after the proposal change, they have to feed back to see whether the proposals have met with the outcomes that were anticipated or not. It's very similar processes.
Very much. That's actually helpful because, as you know, we've been doing an inquiry into access to medicines, and it occurred to me, and I think other people, there's very intensive scrutiny on drugs budgeting, but I wasn't aware how much real scrutiny there was of other services within the NHS, and I think it's quite important to get on the record what is happening with a view to perhaps what happens in the future. A number of boards again came back and said they would like to invest in infrastructure. What sort of infrastructure investments would you be considering? And do you think that's a fairly similar? I know you can only speak for your own board, but do you think there's a commonality across the boards?
Can I kick off
Please.
with that one? You'll appreciate that within Glasgow we have a new hospital which is rapidly coming up, and obviously that's a major investment in infrastructure for us, with 1,109 beds within the new site, within the new facility. The major spend that we will be incurring over the next couple of years will be to complete that. But also, we did highlight within our submission that we're currently in the process, for example, of refurbishing 2 wards at Stob Hill to provide better quality of accommodation for some mental health patients. So I think in terms of investment, those would be the things that I would highlight for you as being bricks and mortar, if you like. But moving away from straight bricks and mortar, we've also made quite an investment in IT systems recently. We've been investing in track care, which is going to give us much greater auditability. You'll be aware of the waiting times discussions that have previously taken place across Scotland. And we've invested quite significant money in a new system because we were criticised not because we had been manipulating waiting times, but because our systems had not been designed to be auditable. And now we will be having new systems which will be much more auditable so that we can demonstrate that we've been squeaky clean on waiting times. It's not for that purpose, however, it's actually to get better patient management, and that links therefore with an electronic patient record that we're putting in, because we've had a number of disparate systems in the past, and the ability to suck that information together and to provide a better quality electronic patient record will provide better quality of care ultimately for patients. In addition, there's another system which we've been investing in, which is called ScriptSwitch. I don't know if I can actually publicise the names of systems, so forgive me, but that's one which is going into GP practices, which enables GPs to prescribe more efficiently, but also more clinically effectively. It has a database that's maintained by our pharmacy specialists, and it sits in all of our GP practices now across Glasgow. I think it's been fully rolled out now, or is on the verge of being fully rolled out. And that enables not only better prescribing in terms of the right choice of drug, but also the right choice of formulation so that it's actually cost effective. So it has a double benefit for us.
take it from the Nords that that's happening in other board areas as well. Is that planned to be rolled out right across Scotland, that system?
I'm afraid I don't know whether it's a board by board initiative, so I can't answer for the whole of Scotland, I'm afraid. But I do know a number of other boards are looking at similar systems.
Just sorry to confuse yourself. Are you finding there are any things that, you know, like maintenance? I know at least one board which has got a big sort of backlog of maintenance expenditure, and are you finding that investment in sort of positive new infrastructure is impacting on maintaining other infrastructure?
Most certainly. In our property and asset management strategy, we've had to make quite a few adjustments in order to try to reflect the impact of the new investments that we're making and the new health centres that we're putting up as well, which are part of the hub schemes moving forward. So the reality is that the backlog maintenance figure that is shown for Glasgow, if you look at the very bald figure, it does need to be adjusted downwards in order to take account of the new infrastructure that we will have in place over the next few years. That doesn't say that all of our estate is not going to, I wouldn't want to mislead the committee, we still do have some backlog maintenance that we do have to do, we do have some estate that is too old, but we are in the process of reducing the problem.
I'd like to comment on the same sort of issues.
It's really just to kind of echo some of the points that Paul's raised. I mean, we're in the process of building a new £200 million hospital. We thankfully got approval in terms of our OBC the other day there, so that's a really critical development for the people of Dumfries and Galloway. We've been fortunate as well in terms of moving forward with two GP practices in Dunscore and Dalbeattie, and again we're taking those forward and they're going through the hub development. So there's other opportunities there for us, I think, across health, and it's whether we're utilising NPD or whether we're utilising normal government capital or whether we're utilising opportunities through hubs. So these are all giving us different opportunities to deliver some of our capital aspirations, which we've all got detailed within our PAMS, which is our property asset management strategy. We still do need to prioritise the maintenance and the backlog maintenance, and that's what we do within our PAMS. And for the past year, within Dumfries and Galloway, we've managed to free up some revenue as well to support some of that backlog maintenance. So it's trying to get the kind of twin prongs in terms of you want to do the development to make sure we hit our 2020 vision, we deliver against a quality strategy, and at the same time making sure that we do recognise that we've got some elements of our estate that are ageing, that do need to be modernised to provide fit for modern purpose healthcare.
If I can perhaps pick up next. Forth Valley is obviously with the opening of Forth Valley Royal in 2011. Our estate was enhanced greatly through that initiative. And we've got 4 community hospitals, again, working through our capital programme at the moment. That's where our investment's been. Our next tranche of our healthcare strategy is looking at our primary care infrastructure, but doing that jointly with the local authorities so that we can make best use of the resources that we've got and the assets that we've got in the communities and make most effective use of those facilities.
Yeah. Mr. Bragg.
I think we're probably just at risk of repeating what my 3 colleagues have already said. I think we are a slightly different stage in terms of our... We've got a business case which we're currently preparing for a new hospital in Kirkwall, which we're hopeful of submitting to our Scottish Health Directorate colleagues in the autumn time. So we've got a slightly different dynamic in there, that we have the pressing need for backlog maintenance and new equipment, but it's trying to tie that investment up in terms of the remaining lifespan, assuming approval of our business case in terms of the new hospitals. I've got a laboratories manager coming to me saying, well, we need to replace the analysers. I've got similar conversations going on in our central decontamination unit, and these are all expensive pieces of equipment which we need to replace, but we need to be mindful of, well, in 5 years' time, hopefully we're moving to a new facility, and it's how can we make sure we're just not actually investing money which we'll just have to write off over the next 4 years, rather than getting the full, because one of the issues within Orkney, of course, is because we don't have the full our instruments, although they run at capacity, that we can tend to get a bit longer lifespan out of them because of they don't actually have the volume going through them. So we're looking at that. I think the other dynamic for me has been in Orkney, especially. I think what we've found over the last few years, I think we all share the same challenges on the buildings, but we've got we as well as we've got investments to make in our IT. We're doing the same as Glasgow are doing, and we've just recently approved a local business case through our Finance and Performance Committee for the implementation of track care within Orkney, and we're hopeful of going live with that probably early in the new calendar year for exactly the same reasons as Paul had set out. It's the systems that have been put in place. They do the job, but they don't do the job now that's required. So But backlog maintenance remains a big issue for us as well, and it's how we handle that while keeping an eye on the new hospital, because we have to keep our statutory compliance up to date. It's something we've worked hard at over the last 3 or 4 years to get to a level of statutory compliance where we're comfortable with it, and we can't afford to let that slip. So there's lots of the money we're investing, which we say, well, we know these new refurbished buildings could last us 10 years, but hopefully we'll be out of there in 5 years when we get the new hospital. So just a slightly different dynamic, one which my colleagues have been through because they're a bit further ahead in the new hospital process.
Will the investment you're making in IT impact on the number of times, say, patients have to travel to and from Aberdeen for treatment?
That's a particular aspect of it, is we're developing a lot of our telehealth capacity, not exclusively. What we've tended to concentrate on the past is putting the capacity into the Balfour Hospital in Kirkwall, so people didn't have to travel, as we could minimise the travel from Kirkwall to Aberdeen. What we're concentrating on this year, and we've done a bit of it last year, but primarily this year, is actually all our outlying GP practices on the Northern Isles, so we can actually save people actually having to come in from the Northern Isles even into Kirkwall for appointments with the local clinicians, and let alone then travelling on to Aberdeen. We use as one of our supporting information. We did a bit of analysis on the travelling times, and if you take the northerly Isles, Westray and North Ronaldsay, for instance, just depending exactly on how the timing of the appointment, you could have someone who's travelling to Aberdeen for a 20-minute outpatient appointment is away from home for the best part of 3 days. So we're trying to, just because of the way the flights work out, because they might have to come into Kirkwall on a Sunday, overnight in Kirkwall on a Sunday night, travel to Aberdeen on the Monday, come back from Aberdeen on the Monday, and then actually eventually travel home on the Tuesday. And it's all for a 20-minute, half-an-hour outpatient appointment. So we're doing a lot of work. We've identified through our GP community some lead clinicians to actually really get into why patients are travelling down to Aberdeen, and we're trying to use that information to target our investment.
It should save money in cash terms as well.
It should save money in cash terms, but I think more importantly, it's the patient journey becomes so much better.
That's helpful. Thanks very much. Thank you, Convener.
Bob Doris.
Thank you, Convener. I was interested to hear Mr James talk about new infrastructure with Greater Glasgow and Clyde Health Board. I represent Glasgow region and stay in the north of the city, and I'm conscious that there'll be a new health centre in Postle Park opening very soon, but also that there's new health centres planned for Woodside and for Maryhill, and I know firsthand that will dramatically improve the quality of patient experience there. I visited Maryhill Health Centre, the old health centre, to speak to staff to find out how they thought the process of moving to the new centre was taking place, and I'm delighted there was significant buy-in. I particularly met with the various GPs and the 4 practices there, and with the community pharmacy. So that's all good news. Now, I did want to put that on the record. It's important we do. But this is a budget scrutiny exercise, and GPs and community pharmacists obviously have got a role to play in relation to that medicines and drugs budget. And Mr James did allude to some of the cost savings that were part of Greater Glasgow Clyde's initiative in the last few years. I've looked at this also in the Public Audit Committee, where Audit Scotland reported in relation to this. The figure £9 million was mentioned. I wonder if it's possible to get some more information in relation to the general increase in the medicines bill within Greater Glasgow and Clyde, because prices tend to go up anyway. But give us some figures around that, but also some figures around the savings in relation to reduction in inappropriate prescribing of drugs in polypharmacy, and perhaps drugs coming off of patent and onto generic, to give us an idea of how future planning in relation to that is going. And I suppose, given the fact that Greater Glasgow and Clyde was singled out as an exemplar of good practice in this area, and we don't always say that, Mr James, but on this occasion we're saying that. What the other health boards are doing in relation to maybe initiatives they have, but also budgetary targets that you have, because obviously hearing from you the initiatives is all very positive, but I suppose what we're looking for as a committee is what are the financial targets you've set in relation to that as well, so that as part of our budget scrutiny of NHS boards we can track that as we go along. So more information on that would be most welcome.
I'll see what I can do. You'll see that in our financial plan for next year, the latest figures show that we're expecting to get about £24 million worth of savings from prescribing. It's fair to say that the vast majority of that comes from off-patent savings. So atorvastatin came down, I think it was, by 93% at one point last year, which was much larger than anybody had anticipated. And as a result of that, because atorvastatin is a fairly commonly used drug, we were expecting to make savings of £4 million straight away. Now, obviously, we didn't get the full year effect of that because it happened during the year in 12-13, I think it was. So the reality is we have an ongoing effect of the atorvastatin price reduction alone within our 24 million. There are also some other off-patent savings in there. So there's quite a significant amount that's come from that. We've got a figure of in the region of 5 million that we're expecting to save as a result of our various prescribing initiatives. We have a pharmacy team, quite a significant pharmacy team, who spend time with GPs and who try to make sure that they prescribe the most clinically effective drugs. They are not a finance team, they are a pharmacy team, they are clinical experts. And they will spend time with GPs and they measure what we call the weighted average cost per patient in each GP practice. So we find that some GPs in similar areas adjacent to each other have, when you would assume a similar patient community, have different levels of prescribing in terms of weighted cost per patient. And as a result of that, it's one of our current focuses is to try to drive out some of that variation because there doesn't appear to be a clinical justification for it. But we leave that to the pharmacists. Although I'm aware of the financial numbers that underpin it, it's not something I influence. And I think it's very important to say that at the end of the day, prescribing decisions are clinically made and rightly so for the benefit of the patient. So we have some fairly sophisticated reporting mechanisms around the variation that exists. I know that the variation that exists in Glasgow at the moment is still, for me, too high. But at the end of the day, the pharmacists will visit the GPs and they will discuss individual cases. So it's one of those things that we just keep an eye on a regular basis. I'm also aware that the accountants have year ends, and there are things that hit one year end as opposed to another. There are clawback schemes from community pharmacists, so at a national level, if it's believed that the community pharmacists have made a bit too much profit or more than was expected, then there is a clawback scheme that brings some of that money back into the boards, and that too is part of the 24 million. So there are a number of components here, but I hope I've given you some of the flavour of what goes on.
It's helpful. Be interested to know how that's repeated across boards, and if you're doing better when you're at Glasgow and Clyde, do tell us. You know, it'd be good to share best practice.
It would be kind of remiss of me not to say that we don't share best practice. I mean, it's very common. We do share good ideas between the various different boards. I mean, there's not a monopoly in one of us having the kind of best prescribing practices. What we have tended to find is the more pharmacists we've got or the more technician support that we've got, we actually manage to drive down the cost. So it tends to be an investment that gets us a return. In terms of Dumfries and Galloway, we are looking to save about £2 million against our £7.5 million from prescribing. Both hospital and within kind of GP practices. Now that's a large number. That number we're trying to push up every year as part of our kind of 3%. So in percentage terms, we are looking to take out just over kind of 5% in terms of efficiencies against prescribing every year against that kind of 3% total target. Within that 2 million, we are looking at about £1 million from patent. We're looking at another couple of 100,000, 200,000 to 300,000 in terms of volume. We also run an incentive scheme with our GP practices. And we've also got some of the PAS schemes that are starting to come through, and that's now starting to reap some benefits for us. So it feels like an open door that we need to continue to go after. We have a responsibility as kind of finance professionals to make sure we go after all of those non-pay elements before we get anywhere near them in terms of the staff and services, and that's what we've continued to do. Paul alluded to some of the work that's been done with Script Switch, which we are also rolling out within Dumfries and Galloway. We're now giving all the GP practices the opportunity in terms of taking that initiative forward, and we'll see what comes from that. I would say for the first time this year, what tends to happen is you look at your prescribing budget every year and you zero base it. So you zero base it, so you build it back up based on what you know is the volume and the activity that's going to come along. Obviously, you've got a finger in there in terms of any new drugs. What tends to happen within Dumfries and Galloway, we've tended to find, is that the amount of new money that we put in tends to get balanced off by the amount of money that we take out in terms of efficiencies, and that takes into account volume. For the first time this year, we've actually got a net reduction in terms of our total drugs budget, which you can understand is an important step for us as an organisation, and it's something we will be continuing to pursue as we look for further efficiencies in future years.
If I can perhaps pick up from Forth Valley, the audit report that was referred to, we would have been one of the high cost boards at that point in time. But over the last 3 years, we've made really significant improvements, and our unit cost per head of population has dramatically reduced, and we're very close now to the Scottish average. It's pretty much on the same basis as Glasgow have outlined around prescribing teams going in and visiting, particularly targeting the higher cost practice areas with similar populations to make changes in there, as well as the standard sort of statin switches that have been outlined. We've had a very successful incentive scheme as well, where we've given support to the practices based on their performance to help with scanning of medical records to help them move towards the electronic patient record and to reduce space used up in their practices and free up space, and that's been very successful and really delivered results for us.
Yeah, I think within Orkney we probably came from a slightly different place. Probably 2 or 3 years ago, I think we were well above Scottish average in all the measures of prescribing efficiency. So we've worked really hard over the last 2 or 3 years. I say we, and it's probably principally our Director of Pharmacy and his team working with their GPs to bring us back down to where we're now probably better than Scottish average on most of those measures. I think the biggest drive we've had over the last 2 or 3 years is to increase our usage of generics. 3 years ago we were probably sitting about 65% usage of generics. We're now up about 84%. We've reduced our defined daily dose cost per patient down to well below the Scottish average. So I think we've achieved at that level of achievement. I think where we're into now is really a very similar to level to what Paul has described, similar to what we're doing with the Highlands and Islands travel. We're now utilising the services of one of our better GP prescribing practices to actually use the inter-practice comparator figures and actually go in and start looking at clinic, because we're into the area now where it needs to be a clinician to clinician dialogue as to why is prescribing practice in one practice apparently more expensive than another, and it really needs to be the clinicians who understand that. We have rolled script switch across all our practices, and we're about 70% of the way through now, looking at the dispensing arrangements. We have still have quite a few GPs on our aisles who have local dispensing arrangements, and we're looking at those. But that's principally around the safety aspects of making sure that the proper drugs are getting dispensed in the appropriate quantities, and they're kept in date and so forth. So we've done a lot of work with our local pharmacies on island, of which we only have 2. We'll have 2 of the national chains on island, so we've taken a bit to engage with them. So we're really at the level now where we're really engaging now with practices at a clinician level to really understand prescribing practices.
Could I just come back in? There's been 2 kind of key developments that would be worthwhile just reiterating. One is we had a CEL issued this year in terms of polypharmacy, which has been very helpful in terms of taking that through our area Drug and Therapeutics Committee. One of the other ones we've got is in terms of the HMUD system, which is a new development taking place within the hospital sector, and it gives us a greater sophistication of information in terms of benchmarking drugs usage across a number of boards. Now, up until now, we've had very good data in terms of PRISMs, which allows us to look at GP practices nationally, and HMUD is a development tool that will give us that same ability, so it will allow us to go in and see and further develop greater cost-effective prescribing within the hospital environment.
Convener, I think that's very, very helpful and really helpful information again for when we do our annual review of budget scrutiny. We can come back and hopefully we'll see greater progress, and we can evidence-base that next year. However, I thought Mr. James did make an important point, and it's maybe worth stressing that all prescribing of medicines is completely up to the individual clinician based on their clinical judgment, and it's about drawing to attention the more appropriate use of medicines on occasions and the efficiencies that can be brought. And I think that's an important thing to stress. I don't think we can stress that too much. The reason I say that is because individual patients may have that patient-GP relationship where they talk about changing their medication, and a knee-jerk reaction from some patients would be, well, why are you doing that? Am I getting an inferior drug? Is this a cost-cutting exercise? And this would seem to be a situation where if we get the message right, because it's about getting maximum efficiency, but the switching of drugs sometimes is to reduce multiple drug taking, to reduce polypharmacy, which is to the patient's benefit, but also just because it's off of patent, there is automatically a cost saving for an identical product. So it's really, I think it's important to stress that, but also perhaps just one of you could maybe answer, because I suspect it will be a similar answer across all the boards. Is there an initiative as part of that process to make sure the communication with the patient is quite clear so that they know when the drugs and prescribing medications they get, that they're not getting an inferior product, and that sometimes it's because drugs have came off of patent? Are they clear in those communications as to why the medications they receive are altering?
To be honest, it's not something you would communicate out. That's between the GP and the patient themselves. They would have that discussion in terms of their drug regime. They would have the discussion in terms of any switches that takes place. Paul talked about script switch. Script switch is a tool that comes up on the GP's machine whenever they're going to prescribe a drug, and it might say, well, there's an alternative drug that you might want to do that's more cost effective. The GP has every right to not right past that screen. So, I mean, when we see how effective something like script switch is, all it is a recommendation. It's still up to the decision between the GP and the individual patient that comes into the practice.
And you're content that GPs, by and large, are getting that right?
Can I just, yes, I think absolutely. I mean, I think it would be wrong actually certainly for finance people and health boards to try to get involved in that communication between a GP and a patient about the choice of drug being prescribed. And so I think Craig's absolutely right. It's down to the individual. The only thing I would add in is that we all do have these pharmacy teams who see the GPs and who therefore also communicate with them. So for example, when atorvastatin came off patent and therefore became a cost-effective alternative to some of the other statins, that communication would take place between the pharmacist, the clinical discussion, and the GP at that point in time. And if the GP then decides to switch the patient onto a different statin, then that conversation will take place between the GP and the patient. So it's a clinical discussion, and it is largely a local one.
That's helpful, thank you.
Is Mr. Doris right, though, in his premise that the variations in price and volume across the boards that are here this morning are all down to that relationship between the patient and the GP? Because there's some significant variation in volumes and price across the boards that are represented here. And obviously, if we had other boards, that would be exaggerated, I presume. So we've got significant variations in price for the GP prescribing, the hospital prescribing, and indeed the volumes. Now, how do you plan in that situation?
Can I start off? I did notice that there was a difference in the summary that had been prepared for you. I think there might be a number of things that you might want to consider. I mean, the first one is that we probably all prepare financial plans on a slightly different basis. So in Greater Glasgow and Clyde, we have typically taken an uplift previously of 6% for GP prescribing. This year we took an uplift of 4%. But we also take significant savings which offset that. And you'll see that also in our plan. Others may not do the same. So I think that's the first thing to bear in mind, that there can be an offsetting influence.
Why should there be a variation in how you plan?
Can I just finish? Can I come back to that?
Yeah,
but there's also, I think, a very important second point to make, which is that we are all at different positions in our prescribing practices around Scotland, and it's fair to say that some boards have had more success in reducing the weighted cost per patient than others have done. And for that reason, it would be perfectly valid for different boards to set different percentage targets in terms of their aspiration. We're fortunate in Glasgow that we've managed to get the lowest weighted average cost per patient in Scotland, but that means other boards have more opportunity than we do looking forward. In very broad terms, I mean, forgetting all of the clinical discussion, in very broad terms, simple financial terms, they have more opportunity to take reduction. So I can see a whole load of reasons why different boards would take different planning assumptions in terms of savings on prescribing.
There could be any number of reasons. But who do you justify them to? Who do you explain that you've worked out differently, and when you're, sticking out like a sore thumb or not the norm? Is there anybody who says to you, just as you do at the GPs, you're sticking out here? Why is this? So when you plan and you come up with results of that, is anybody saying to the boards, why are you different from the norm? How do you justify that planning assumption in terms of your costs? Is there anyone who does that? Yes, Mr. Martin.
We've got responsibility. We've got responsibility as professionals to have that discussion internally. So we will have a look at the numbers that are popping up from different boards. There's a systematic approach to it, and that's when we put in our financial plans into the Scottish Government. The Scottish Government will play those numbers back to us. There has to be a realisation, though, that we're maybe comparing apples with oranges, because what Paul was kind of trying to allude to was the fact that for last financial year, if I was to look at my prescribing budget, I was £1 million underspent. Okay, so that £1 million means I've got that in a recurring baseline. So when I'm looking at that net increase against that, I'm taking that on the basis I've already got £1 million sitting there to put towards my volume increases, to put towards my price increases for the next year. Other boards might be in slightly different positions. They might have budgeted slightly differently than the previous year. So Paul within Glasgow might be at a break-even position. Fiona might be at a slight overspend position. So the amount of money that they need to put in every year would be slightly different between individual boards. We all take slightly different views in terms of our incentive schemes, but they're very similar as well. The national work that's taken through the efficiency framework pulls all of that shared learning together. So we're all constantly trying to drive that cost down. I mean, Paul's mentioned the fact that he's the #1 kind of cost prescriber, and well done to Paul, but there's the bit about we're all trying to get there. So we're all trying to learn from each other. I mean, if you look at ours just in the pure per capita, we're about 10th or 11th. If you look at ours per weighted population, we're 4th. So we have different mixes of populations, we've got different ages, we've got different mixes in terms of the drug regimes that take place, but we're all constantly working very hard in terms of trying to drive those costs down. But your question in terms of who looks at it and plays that back to us, the Scottish Government plays that back to us. But to be fair, we know that answer before it's played back to us.
So they've spoke to you about the variances, and they're happy that all the factors there are
We justify it. We'll all have area drug and therapeutics committees. That's how your budget's built up. So it's built up by the professionals, look at it from a kind of baseline position, looking at it in terms of volume, cost, what's coming off patent, what's coming forward in terms of SMC advice in terms of new drugs. We build that position up as part of our ADTC discussion. That takes place both with the health
ADTCs have got a budgetary role as well.
They've got a budgetary role in terms of reviewing the budget.
It's interesting to hear that, because we haven't heard that over weeks of discussion, the access to drugs that they've got. I think a budgetary aspect to it. It was about efficacy and safety, etc., etc. So you're introducing something new this morning in terms of they have a budgetary role as well. But I mean, I think some of your colleagues wanted to respond.
The other thing, it was just to add from my perspective, is it's a bit about challenge and sharing. We do that through our pharmacy networks, we do that through our financial networks, so we're aware of what uplifts and what benchmarking information is available. So for us, for example, where we were high cost, we had gone to Glasgow to go through the processes that they had used, and it was because we could see from the benchmarking information. So that's a challenge back. The challenge locally then is you can see that we're sitting as high cost prescribers. So there was a challenge locally to go away and make that better, given that the position that Glasgow was in. But we do share information through all our clinical and financial networks to ensure consistency.
This point about whether these planning presumptions that everyone says it might be slightly different here, there, and whatever, and we all come to a happy point anyway. And, you know, is there not a role for the Scottish Government to say, well, here's the planning assumptions you should take into account, and if you want to depart from that, you make the case for that, you know, that local area or that local consideration, rather than what you're doing now, which results in all of these variations. Is there a role for the Health Department of the Scottish Government to say, well, here's the planning assumptions you should all consider, so that there's you know, give people like the lay people around here an opportunity, a small chance to apply some scrutiny to this process. You know?
The process that you've articulated is the process that we operate with. Because effectively we get SMC advice that tells us about the new drugs that are coming forward. So we'll take that into account locally in terms of understanding how our budget has got to change moving forward. We then take that back locally. We look at it in terms of our demographic region. We look at it in the basis of how our GPs prescribe. We take into account all of those local factors, and that's how we come up with our
and you
local
can
budget.
decide whether that drug is available in your area as well.
Well, we've got the SMC advice that clearly...
But you don't always, you take a long time sometimes to implement the variant. Is that part of the budgetary process as well?
It's all taken into account, yeah.
Pardon?
It's all taken into account.
It's all taken into account. Yeah. So the delay could be to a financial year or whatever.
Sorry, to be clear, we don't make a delay in terms of the ability for the drug. We make a budget assessment as part of ADTC in terms of when new drugs will come on stream. So every year we will sit down. I mean, the big one is obviously in terms of cancer drugs within our hospital environment. Now, we will make an assumption in terms of when those drugs will come forward. We will budget for it. Eggs are eggs, we get that wrong. But we need to be prudent in terms of our assumption that we're putting into our financial plan.
Okay. Mr. James?
Can I just say, I mean, I can appreciate that it's difficult for this committee to do an effective scrutiny over prescribing expenditure because it is a complex beast. You start off with the expenditure in the previous year. You know what you've spent in the previous year. As Craig said, you get that wrong at the year end because the figures come out 2 months late, and after you've made your prescribing accrual in your year-end accounts, and then you find out what the real figure was during the audit, which is just a fact of life for us accountants. But he underspent by £1 million. In fact, so did we, as it happens. And so that tells you, if you like, your start point for the next year. The first thing you then do is say, what do we think we're going to have in terms of inflation, in terms of volume? What do we think also of the existing drugs that we know that we spend money on will come off patent, because that's a significant factor in the equation. We then look at the drugs that are coming in, the new drugs that we're expecting to see coming through SMC, and as you rightly say, will come into our formulary. And we have to look at the time when those drugs will come in. All of that forms part of the picture of where we expect to be in terms of our expenditure for the forthcoming year. So if you want to scrutinise it, you're going to have to get into each of those different factors. But I would have thought that a way of scrutinising it, because I think it's the way that probably we accountants look at it, is to think about this weighted average cost per patient and to understand how that is changing and to think about some of the big factors that are hitting the prescribing budget, such as off-patent savings and the pharmacy clawback that I referred to earlier. And if you get into some of the bigger numbers, that might, I'm only trying to help the committee, but I think that might be a helpful thing for you next year to design some questions around that sort of area.
It has been helpful, but, you know, I think, because other than drugs and medicines coming off patent, you've very difficultly planned reductions in it. How much of the 24 million is due to the clawback and other measures, and how much is the 24 million due to drugs coming off patent?
I don't have the breakdown with me, but I would think we're talking around about 3/4.
3/4
due to patent, clawback, and other factors of that sort. Yes.
Yeah.
As opposed to what we would consider to be prescribing efficiency, conversations with GPs, that sort of stuff where our pharmacy professionals get closely involved.
And I suppose the other thing that we're searching for as a committee, and the net alluded to some of that, you know, in terms of how much we are reviewing and monitoring within the health service, you know, and that type of scrutiny, for little return it would seem, but being applied to other medicines that are still around, because we don't see anything disappearing. You know, we see new medicine coming on, new procedures coming on, but we don't see a lot being disinvested or, you know, you know, in that. You know, we don't stop doing things. We do the things we always did, and we do the new stuff as well. And there's a
that's really the critical issues in terms of polypharmacy. When you look at the number of people that are on over 5 medications over 65, and that's continuing to increase. So polypharmacy is the key issue for us to get in and start to review those number of complementary medicines. Because one of the kind of key issues you get is as people get older and take more medications, it's the kind of falls and trips, and sometimes people will end up in A&E, and it is when you start to review those drug regimes. So that's why the polypharmacy CEL has been very helpful for us. When we do get new drugs that are coming forward, and we get the SMC advice, we also get the SMC advice in terms of the complementary drugs that we should be stopping at the same time as new drug regimes come forward.
I think Bob's got a supplementary, and I've got a couple of others to come in, but the reason I think we're focusing a lot on this is because of the inquiry we're carrying out. But in terms of the budgets, in terms of costs and efficiencies, it's all been the prescribing budget is where everybody says that they can achieve some of these, or certainly one of the risks that we need to focus on about that rising part of the budget. But we'll come to some of the efficiencies and cost savings later, I'm sure. Bob, you wanted supplementary on this?
And I will try and keep it brief, because I know my colleagues want to come in with other questions. But it's back to the scrutiny thing again. And first of all, just kind of want to clarify, I don't think we should conflate the access to new medicines review and drugs being local formally with the financial assumptions that the boards are making. I think that could be a dangerous conflation to make. We understand why we might do that. In terms of the information we've got before us for future scrutiny, before me just now I've got under cost pressures, I've got under the headings of GP prescribing, hospital prescribing, I've got prices, I've got volume, but what I don't have sitting beside that is the overall change to the drugs budget. What I don't have sitting beside that is where the savings are from off-brand. What I don't have beside that are savings from other measures boards have taken, and what I don't have beside that is what your targets were for 12-13 and what your estimates have for 13-14. Quite frankly, I suspect you have got all this information and you have been scrutinised to the nth degree, just not by this committee. Because Audit Scotland did a tremendous job actually of providing that scrutiny as well. So the reason for coming here, Convener, is to make sure that perhaps under those headings I've given you, and other ones that you might think are appropriate as well, perhaps you could give that information in writing to the committee, and that would gear us up for some effective, informed scrutiny when we return to that this time next year. Because I don't even think when we are scrutinising, we're comparing apples with apples ourselves. I think we're conflating different things, and it would be helpful if we did it from a baseline that we clearly understood.
I think there was a request in the question for some additional information. You know, the committee would be happy to receive that. Jane Baxter.
Thanks, my question is not about pharmacy. It refers back to some conversations that took place earlier in the session, and it's about when services are redesigned or resources are moved around and things change in communities and for service users. And I'd like some reassurance that there's a bit of impact assessment goes on around that, and some consultation with service users and with community plan partners and possibly with staff. I'd like a bit of information about those things, please.
Start with that one. Obviously, we've been through a major healthcare strategy implementation and a full consultation process associated with that. That included, for example, our work around our community hospitals and the services that were provided through the community hospitals, because obviously we were moving from 2 DGH sites into one acute site. Building on that, there are changes as you go through, and services change in different reasons, and we've always worked through locally, particularly with the service users, about any changes that impact on them. The change in facilities, the change perhaps in location depending on what it is, and taking into account any access issues they may have, and any concerns they may have, and broadly that we come through that process quite successfully, certainly locally.
Yeah, maybe if I just add an Orkney perspective on that. We're obviously going through the process at the moment of redesigning our hospital-based services, and some of our primary care services for hopefully moving into a new hospital facility in about 5 years' time. So we've got an extensive range of groups set up to actually consult and engage in dialogue with various groups, whether it be patients, public, staff. So we've got that. But also what we do is for each of our aisles, we engage very heavily with the local community councils, the local development trusts, and we're doing anything on any particular aisles as well, because each of the aisles is almost different in their own way and what they want. And we've certainly had situations where we've went out with, this is what we would like to do, and then following the dialogue we've had, we've come back and we've reflected and we've changed, perhaps taken on board what the community want. And the GP services on Hoy would be a good example, where we came up with the community actually said to us, this is what we would like, and we said, well, okay, that's the way we can go down. So it works tremendously well. But the importance of the consultation and the dialogue with all the stakeholder groups really just can't be overemphasised.
Anyone else?
Can I just
yes,
add? We gave quite a lot of information on inequalities in our response to the committee, but I would just point out a couple of things. I mean, the first thing is that we do have a process which is called fair financial decisions. So we do try to make sure that all of the savings challenges that come through and the savings processes that come through are properly evaluated for equality impact. And the second thing to say is that our equalities team don't view equality as an add-on at the end of the normal operational management of the business. They view it as an integral part of the business, and they're forever preaching that message and making sure that we all understand it and do actually adopt it.
How do you look to the question of the public health screening and others, where poorer people do not engage in that as effectively as others? What have you did to ensure that there's as part of that process? What have you did to ensure that there's a greater uptake or reach out to those people? Or
one of the ways in which it's embedded within the process is that when we're doing things like screening and healthy weight for children and that sort of stuff, we actually focus the efforts more significantly within the deprived groups.
Has that brought you a return? What sort of evaluation and what monitoring is taking place to ensure that that strategy has been working and is working? Have you got some information on that, committee? I
do. And I'll pull something together for you.
That's fine.
Yes.
Thanks. Drew Smith.
Thank you, Convener. I'll just return briefly to this issue around pharmacy, and then I'll move on from that. But I mean, can you understand? I suppose I just really want to understand this issue around cost per patient in terms of prescribing. I think you maybe described that as a weighted cost per patient. I wonder if you can just tell me a little bit more about what the weighting in that involves, because I mean, clearly there is a lot of public concern about access to medicines at the moment, and particularly access to, frankly, expensive medicines. So purely looking at the situation in terms of cost per patient would raise concerns if behind that we were then actually failing to understand that some of the higher costs per patient were driven by those boards that were actually providing the range of medicines that people would want to have access to. So could you just maybe reassure me on that?
Yeah, I mean, we've got a kind of cost per patient, which is just a straight cost per capita across the population. So we see where we sit within that. We get a weighted cost per case, and that takes into account age, takes into account demographic split of the population. So that takes into account all those factors to give you a more accurate comparison cost. But these are, to be fair,
to take into account the cost of the treatment, so the cost of the medication. So at what stage, so if it's an innovative new medicine, then clearly it's going to cost more, and why would we want to be driving down access to those medicines if at a separate part of the board we're saying we want to increase access to these medicines where we can because they're new and innovative and we think we're going to get good results from them?
To be fair, that's probably two different discussions that would take place. I mean, all we're really referring to is in terms of we would get information that would come off our primary care system that would give us that weighted cost per patient, and we would get information that would come off and just give us our costed element per patient. The discussions that you're talking about in terms of new drug regimes that are coming forward and how they're rolled out across the board, I mean, that would take place within your area drugs and therapeutics committee. That would take into account how that would therefore move on to your formulary, so that would take into account your budgeting process going forward. So it's not
I understand that, but if part of the issue around this is variation between the boards in terms of access to medicines because different decisions are being made. So if we're making a judgment, if we're comparing boards purely on the cost per patient, then how do we take into account the fact that some boards may be making different prescribing decisions that we would want to support?
It's maybe something that would take place as part of a review in terms of formulary between different boards and what drugs are available within those formularies between the different boards.
Okay. Could I ask maybe just, Mr. James, I think it was the 24 million that you mentioned. Could you just help me with that? Was an annual figure? Yes. Could you give me some indication of what you spent the 24 million on, and when, once you'd saved it, where did it then go?
I see. Well, the 24 million forms a part of the overall figure of 59.9, which is reported in your packs as being our overall savings programme. Some of that 59.9 is made up of non-cash releasing savings. So we've got 33.7 million of cash releasing savings, of which the 24 million is obviously the majority. So in terms of where the money has been spent, you have to look at the overall expenditure plan of the board, and we compare that with our funding, and then obviously we have to take off the savings in order to bring the two into balance. So I can't tell you where I've spent the 24. I can tell you where I'm spending all of my money in the board, but the 24 is part of the overall equation where we're balancing our priorities.
I suppose what I'm asking for is, could you give me a rough percentage of how much of that money stays in medicine? So how much of the money that we say this has come off patent?
Pretty much all of it goes into medicine, because we've put into our pressures in 13-14 around about 29 million for prescribing. So we're not actually taking a significant net reduction in prescribing in 13-14. In the past, we would have had a net increase in prescribing, because we would not expect to get those sorts of savings that we're expecting in 13-14. And this, I would emphasise, is, I think, going to be pretty much a one-off year for us. I would not expect that to repeat in 14-15 or 15-16. And to come back to some of the questioning that the convener asked earlier on, that may not be true of other boards, because some other boards have the opportunity to further reduce their weighted cost per patient, whereas we think, there comes a point where you can't continue to do that. So from our point of view, I think 13-14 is the year when we see the benefit of prescribing of that scale for the last time within Greater Glasgow and Clyde for a period of time.
I think that's helpful. If I could just move on briefly, I think it was Bob Doris that mentioned the Audit Scotland report, which looked at 11 and 12, and one of the big concerns that Audit Scotland had there was around reoccurring deficits, and they did criticise a number of boards for relying on one-off payments in order to break even through the year. Could you maybe give us an indication of whether you think that's likely to be a problem for you in the boards that you represent next year? Or this year? Right?
Yeah, I mean, probably if I kick off, is that probably NHS-Boards-Budget-Scrutiny was one of the boards mentioned in the Audit Scotland report. I mean, we've come for a period where probably 3.5 years ago we had a recurring deficit in the order of 3.5 to 3.75 million pounds. We're probably touching on 10% of our core RRL, so we had quite a challenge to achieve. With our Scottish Government colleagues, we developed a financial plan which had the objective of returning us back to recurring financial balance at March 13, which I'm pleased to say we have achieved. What was instrumental in that was actually a range of non-recurring support from Scottish Government. That was probably manifested itself in a couple of ways. We had brokerage support to get us over well savings were delivered, but we also had a particular issue for Orkney over the last couple of years has been where we had support in relation to off-island activity for those health boards where we didn't have contracts with which the Scottish Government gave us some non-recurring support. So we had non-recurring support in 12-13, but this is the end of it now. We've now moved into a recurring balanced position. What we're just working through with our audit colleagues at the moment as we finalise the accounts is just to make sure that's all clear. I think is as they were speaking about is the transparency in the year-end accounts. So yeah, but we've made full disclosure through our board and it's in our LDP approval letters in terms of our agreed repayment brokerage now in 13-14 is where we start repaying the brokerage we've had, and we've got a 5-year payment timetable over that. We make the £750,000 per annum we will pay over the next 5 years to repay the brokerage which we've had from Scottish Government. But in terms of ongoing support from Scottish Government of a non-recurring basis, no, it came to an end in financial year 12-13 for Orkney.
Can I maybe just play a kind of slightly different position? I mean, it's a recognition in terms of the kind of over £11 billion budget that's managed through health. I mean, we looked for brokerage last year, but it was brokerage the other way. We were going through a strategic change in building a new hospital. And when that hospital's up and running, we're going to need money for double running costs while we run the old facility and we move to the new facility. So we've been trying to bank funding with the Scottish Government. So past couple of years, we've managed to secure some non-recurring resources. So we've banked that with the Scottish Government. So effectively, that's brokerage going one way. And other boards maybe be taking brokerage in a slightly different way. And that flexibility certainly helps us because that money will come back to me when we move into a new facility so that I can plan on a suitable basis to make sure that I've got enough resource within that difficult financial year to run both services.
Just to answer your question, we're not expecting any support from the Scottish Government other than the normal funding process. But I would support, in a sense, the point that Craig's making, that the ability to carry forward money is very helpful, and is something which I think many boards would appreciate, that flexibility to help us to manage the budget in a more sustainable way.
I think to just add from Forth Valley perspective, we've been in both situations where we actually had, as Craig's described, banked money when we were making our moves so that we could access additional resource at a time when we were working across 3 sites as opposed to 1 that we were moving to. But we also did require some support because our actual moves impacted in the same year as really the economic challenges really hit the whole country. So we did require some support. We're well on the way to repaying that amount. We would hopefully repay it a year earlier than we had planned to do. But I think the other thing I would also, you asked about underlying deficits. We've set a balanced budget, a balanced recurrent budget for the year coming, but also for the years beyond that. It is important to stress it's about longer term planning. It's not just about next year, it's also about the 2-3 years and the pressures and the demographic changes, because change takes time to work through. So we do need to be clear that we're doing that on a longer term basis and not just on a year-to-year basis.
Well, I think it's yourself, Ms Ramsey, where you've been through that process and, as you say, seen it from both sides. What is the flexibility that you require around that? Because I suppose my question for Mr O'Brien is based on whether or not, if you needed a loan to break even this year, you know, I want to know whether or not you're going to need a loan to break even next year and for the 5 years that you're in repayment. So you said you paid early. What are the factors that change what you can do based on what you think you can do at the start of the process?
I think what I was trying to explain was we'd actually banked money well before we moved to Forth Valley Royal, so we'd banked over £8 million with the Scottish Government to help us, because we knew we needed double running costs. You've got rates bills into sites, you need IT infrastructure help across sites, etc. So it's important you've got that flexibility to take money when you actually need the money and have that resource. In terms of us repaying, because we did get the help, what we've been doing, because it's all built into our healthcare strategy and we were rationalising our footprint and the number of sites that we were actually working off, it's tied into our property sales. So it's the timing of the property sales and actually making sure that we're well in place, certainly for us, to market those sites, to have any conditions associated with them as smoothly dealt with as we possibly can locally, to make them as attractive as possible. So that's what's helped us.
I think Fiona has picked up one of the key points, and probably one of the things that we had to address in Orkney was actually developing that much longer time period of financial planning and not trying to survive from one year to the next year. We've actually developed a financial model that goes out over 10 or 12 years so we can understand exactly where we're going to be, and that was the whole basis of actually agreeing brokerage with Scottish Government, in terms of that we could clearly demonstrate that we could make the efficiencies and the savings in order to repay the brokerage over the next 5 years' time. So we actually run into a period now where we're actually into recurring surplus for the next 5 years, which allows us to repay our brokerage, but that recurring surplus is actually required in terms of the way we want to develop the services when the new hospital comes online. So the areas begin to mesh, and I think, as Fiona says, and lots of our brokerage was about timing of delivery of savings and allowing us that, probably buying us that important time to actually go over that hump where we could actually make the efficiencies. One of our big issues, as I've said, was off-island activity with especially non-Grampian boards, and what we've done now is we've got SLAs basically with every board in Scotland. We've entered into risk-sharing agreements for the more specialist services, whereas in the past I suspect the board was trying to survive on the basis, well, we'll hope it won't happen, but of course it does, it always happens, and it's allowed us, so the brokerage has been tremendously helpful in us in terms of buying us that time to get into a much stronger financial position. But the key element to me is exactly as Fiona said, was actually developing that much longer time frame of planning and understanding, all other things being equal and based on a robust set of assumptions, where do you think the board is going to be in 5 years' time? Can it actually afford to make these payments? Can it actually understand, and have you made proper cost allowances and pay award, etc. assumptions? And probably just going back to the discussion on scrutiny we were having earlier on pharmacy. That's one of the big areas where our Finance and Performance Committee comes into play, where comprises 4 or 5 of our non-executives. We go through all of our underlying assumptions in a lot of detail. We don't concentrate so much on the numbers in the early days of our planning. We actually understand where is our planning assumption sit in comparison to other boards, to the rest of Scotland, and so we use our non-executives to get that level of scrutiny as well. But the big issue for me has really been the timing issue to allow us to get onto a much stronger financial footing.
But when the Scottish Government loans you this money, do you provide information? Do you make some of the assumptions around future property sales and all of that? So they've got that information and they've essentially banked on that you're going to do that? Yes,
that's it. We had some small property sales and then we identified, I think, 6 properties for sale, which we've now sold 4. We've got another 2 to go, which repaid a small element of our brokerage, but our basically was based on us getting back into a recurring revenue balanced position. But no, yes, we had to. We went through quite a lot of detailed financial plan evaluation with our Scottish Government colleagues. So it wasn't just based on here is a high level plan. We really did quite a bit of diving into the level of detail to make sure we had the proper assumptions in there.
Just kind of one thing. Finally, Convener, I suppose though it is quite a general point, but one of the other concerns that Audit Scotland raised in the 11-12 report was that 20% of the savings that boards were identifying were high risk. I wonder if you could maybe just give us a flavour of what high risk saving means to you and your board. What sort of things would you class as high risk? I mean, I presume that property sales is going to be one of them, for example.
No, I mean, it's an interesting dialogue because at the start of the year we split up our risk analysis against each of our efficiency programmes. I mean, as you can understand, as we progress through the year, that risk profile will change. Some of those risks against those schemes will remain high risk until you actually start to deliver. Some of the biggest ones would probably be around about service change. If you're looking to change one service, or if you're looking to deliver outpatients in a slightly different way, if you're looking at some bed reconfiguration issues, they would tend to be your kind of high risk areas. And again, they wouldn't change into kind of medium to low risk until you actually start to deliver them. So, I mean, if I look at my risk profile just now, my risk profile, high risk is about 20-odd%, about 23% is my high risk at the moment for the current financial year.
Mr. James?
I would say our figure is much lower than that, because in 13-14, if you say we're looking for 59.9 million of savings, of which 33.7 are cash releasing, 24 is prescribing. I'm confident about that 24. I wouldn't have put it in the financial plan. So in terms of risk, I'd say that's not high risk. There's a remaining 9 million, which is cash releasing savings coming from my acute and partnership divisions. We have already, in reaching that figure, we have already taken out all of the high risk items, because we had a higher figure in terms of savings proposals that were originally submitted by our acute and partnership divisions, and we consciously deleted all of the schemes that were traffic light red. So all of the schemes that we have in our savings plan are either green or amber at this stage, and they are much lower than the previous years. So I would say, from our perspective in Glasgow, I wouldn't want to place any high risk as being there. The only thing I would say in terms of high risk is what Craig says in terms of achievability, more than acceptability, if you like, or impact on patient quality. So in terms of achievability, yes, there's always going to be some issue about whether or not some of the schemes will be delivered in time. But at this stage, and I'm touching every bit of wood in the room, I think we can say that that we believe we will deliver those schemes within the year.
Just to pick up as well, I think for us our risk profile changes over the year as you get more confidence with some of the areas coming through. A couple of examples for us, we'd already mentioned service redesign. That may mean that there's a workforce profile change, so you may have a skill mix change within the workforce that you need. You need then to be able to move, if it's a higher cost staffing mix that you've got and you're changing that, you need to be able to relocate those people into alternative roles. So it's a timing change that will cause that to be high risk. It would move to low risk when you were able to free that up. The other example for us is we've got certainly a tackle around our temporary workforce spend, around our bank spending, etc., to make sure, and some of that links to our current sickness absence rates. So we're tackling that, but you'll get confidence as some of that starts to come through and you can start to materialise that. So a couple of months into the year, our risk profile would change.
I would agree with Paul's comment there. I think the categorisation of low, medium, high really goes down to achievability rather than acceptability. I think that's a good way of putting it. I mean, we've now identified savings schemes for all of our savings, and I'm probably sitting here today probably with about 10% of them in terms of still in the high. If we were using that categorisation, we're probably sitting with about 10%, about 100,000 to us sitting in high risk. But what we've very consciously taken a view on at board level is we have linked very much the savings delivery with the investment plans. So we don't. So there's definitely some of the investments where we say to the managers, well, that's your prize for delivering the saving, is that we will then release the investment fund. So we try to get that careful mix. But of course we've got the investments like our HD unit and our CT scanner, where we say, well, we need to progressing them because we can't wait until all the savings are delivered. But we do try to make sure within our investment plans that we've got some investments which we can slow down if we need to, if the savings don't come to fruition.
Just interested in the discussion this morning with some of the other things that are coming into play, and the achievability in this year. I suppose the next thing, picking up with Mr. James, in terms of the prescribing bill is 24 million this year. You're not expecting that to go on. Is the whole question of sustainability of this process? Some boards will be further on than others, so they have made those efficiencies. Some others will follow on and see what was done and adopt that best practice. And there seems to be, alongside those challenges, increased demand, less money to do it with. How do that sustainability? How do we move on and ensure the quality of the service that people expect, deliver the service efficiently, and whether that's going to, I think that's not going to become easier but more difficult. The other thing that was interesting me as well was some of the issues about carrying forward flexibility and indeed earlier on earmarked funds. There's a whole lot of bits and pieces that maybe if you had greater control over, you could actually be in a better position to plan over the next 5 or decade than you currently are now, because the earmarked funding comes ring-fenced, accountable, monitored. You've got to spend it on that, and you've got to show you're spending it on that. So you're spending it maybe not in the best way, just to meet the target, or you could maybe spend it other ways. I'm just searching for some of the, when you said carry forward and flexibility and things, people were nodding. How could we improve the situation for people like yourselves? And is there a suggestion that we should take into account that we can improve the situation a bit, for yourself?
Can I kick that off? 2 points, sustainability and carry forward. It feels to me, is this a process that's sustainable? I think it is a process that you have to go through, because you've got to set some savings targets or some sort of financial plan. You've got to have some sort of boundaries around which you set it, whether it's a year, whether it's 3 years, whatever it is. So to that very simplistic perspective, it's sustainable. The point, though, that you're making, which is about is this something we can keep continuing? And in Glasgow, as I've already explained, that the level of prescribing savings is, I think, greater in 13-14 than it will be in 14-15. That, for me, means that we need to plan medium term. And I've mentioned this to various colleagues at different times. So I'm making great efforts to take my management team and my board through a more longer term planning process at the moment. And we're trying to look at all of the areas of clinical service that we provide, and we're trying to say, where is it that we are efficient and inefficient, to do some benchmarking? Which ones do we want to expand? Which ones do we want to stop? There's going to be a whole series of more fundamental debates about how we plan over the medium term. And we have to bear in mind the fact that, and this will be different for all the boards around the table, we spend £1/3 every hour. So, the sorts of numbers I'm talking about around the table are very different from the numbers that some of my colleagues are saying. You have to get the relative materiality right. But we've got a new hospital coming in 2015. We've got integration starting in April 15. And the reality is those two things will have a significant impact on my cost base moving forward. So now is the time, I think, to do some medium-term planning, certainly for Glasgow, and to make sure that we understand what the impact of the new hospital will be on our cost base, to make sure that we understand how much money we're going to put into HSCPs moving forward, and preparing for all of that. So I'm looking at a sort of 3-4 year horizon in my financial planning at the moment. Now that's only just begun, so I'm afraid I can't give you any details behind that, but I can tell you the process that we're embarking on, and we will stick to that. We need to stick to that.
See, I think it is interesting to the committee who have focused and looked at the preventive spend, and it's mid-term, but the preventive spend is very much the longer term. I understand the pressures. I mean, the building of the New Southern General gives you 1,100 beds. You don't need or want an additional 1,100 beds.
No.
So that gives us what's doable in terms of all these other hospital beds, where they are and whatever. I'm speaking for an Inverclyde perspective here, not just the convener of this committee. And we've got the clinical review. Do you see the clinical review as a central part of that mid-term analysis and management of the challenges?
Yes, very much so. I mean, the reality is that I wasn't around, but back I think in 2002 there was an acute strategy review for Glasgow, and that generated various changes to our service provision, and it culminates to some extent with the building of the new hospital, which is 2015. But we have to look beyond 2015, and we have to make sure that we are prepared for the longer term. So yes, the clinical services review that we're embarking on is designed to achieve that, and is designed to look, for example, at chronic conditions, the pathway of care for chronic conditions. What do we need to do and change to provide better care?
From a budgetary point of view, what do you expect that to deliver for your budget, that clinical review?
Well, and that's exactly why I've launched our medium term.
Is it standstill? Is it what?
we're not at the position where I yet have financial forecasts going forward with the clinical services review, and I'm happy to try and keep the committee updated.
The board have went ahead with that without that information.
The board started the clinical services review, in my view, quite rightly, with a clinical focus, and said, let's just work out what the right way is of delivering care for patients over the next few years. And what I have done is I've backed that up with a medium-term financial strategy, which is increasingly going to integrate with that piece of work, so that we make absolutely sure that the expectations that we're talking about in terms of service design and delivery are genuinely affordable and deliverable. And it's not just about money, it's about facilities and infrastructure, and it's about people and skills. So we have to make sure that all of the practical constraints that we have, our clinical aspirations, are realistic. But that piece of work has only just started, and I think I can't give you any great details about it at this stage.
So they'll certainly not get a blank cheque from me, I'm sure.
I'm afraid, as a finance director, you wouldn't expect me to say yes, would you?
Anyway, I'll not press you further on it, but I mean, I understood that it was going to consultation in October later this year. So
yes.
If we've not done the sums round about that, then...
No, we are doing some sums, but we haven't got them yet.
Will they be available by that? No, I'm not. Aileen McLeod, thank you.
Thanks, Convener. And it was somewhat related to some of the points that the Convener mentioned earlier, and it was around the issue about the potential savings that you anticipate from the various initiatives and projects that you have as part of your preventative health programmes. And I'm keen to know more about the extent to which the assessments are being made by boards of the potential long-term savings from preventative spend, and any modelling work that you have been doing to help with that assessment of preventive spend, and also for future financial planning. I mean, I know that there are some examples of best practice, for example, with the Matheson Galloway Health Board, but obviously you have your Putting You First programme, and I think it'd be quite good to get some of that on the record today, if you could perhaps explain a bit more about that programme, and also in terms of what Orkney's been doing as well in relation to your impact analysis.
Kick off. I mean, we kind of led the discussion around about the Change Fund and Put You First, kind of similar, just in terms of how we deal with it. Putting You First is our programme in terms of looking at our older population, how we work between local authority and health, and how we deal with that ageing population. I mean, our numbers are pretty stark. I mean, 21% of our population utilise something like kind of 40% of our resources. That's over 65s. By 2035, 46% of our population will be over 65. So we've got some pretty stark choices. We've got sustainability issues that we're having to take forward. As part of the Putting You First, we're working with social work colleagues in terms of looking at all of these issues in terms of our ageing population, and seeing how we can deal with some of those demographic changes in terms of how we're going to change our services, because clearly sustainability will play an impact on that. Putting You First it's interesting that you play it back on the basis of we're doing some good work. I think we are doing some good work. I think we're still probably at the kind of cusp of understanding what some of those changes are going to make for us. Preventative spend from a director of finance perspective is always one of these things where it's always just out with my financial plan in terms of any changes that are going to come forward. The reality is, though, that we need to be sitting there very closely with commissioners, with service providers, and actually saying, right, okay, if we make this change, what's that going to mean for us further down the line? We've got an evaluation team that's working round about Putting You First, and they're looking at 3 different aspects of it. They're looking at the kind of qualitative, they're looking at the quantitative, which obviously I'm interested in, and they're also looking at it in terms of evaluation of the pilot projects. We've had some updated reports from them, and they're now starting to articulate how difficult it is in terms of actually doing the various different elements in terms of the reviews, but we need to stick with it. The clear thing with any of these projects when you take it forward is you need to be very clear what are the outputs that you're going to get and how you're going to measure against those outputs. It's very easy for us to get the kind of patient story and how that's changed in terms of the patient story, and our non-executives are pushing us very hard to understand that element of the patient story. There is the bit from the financial perspective that I'm looking to the future. I'm looking to that kind of medium term, that longer term, in terms of that ageing population, in terms of the way that we provide our services, in terms of the way that we utilise our resources and our services have got to change. So we're quite clearly utilising all of that money that we've got within the Change Fund in terms of creating those kind of kernels of change and actually seeing what comes from them. I lead one of the work streams, and it's about supporting people at home, and we're doing some interesting work with some of the voluntary sectors, and it's about good neighbours, and it's about volunteers coming onto the wards, working with the patients, helping them who maybe haven't got strong kind of family bonds, helping them to get back to their homes as quickly as possible. That also works through in terms of good neighbours when they're in the community as well, and helping to avoid admissions into the hospital. So we're looking at a real wide spectrum of different services. The difficulty is actually just trying to pull it together and seeing what's actually changed. We have got from the JIT some kind of clear metrics that we're supposed to score against. And one of them this year, I think it was the over 75s emergency beds, and we've got a target for 2015. Now, we actually hit that number surprisingly within 2012, and again, it was one of these things where you're sitting down and saying, well, is it something that we've done within Putting You First? Is it about what we've done within the Change Fund? And it's multifaceted. The thing is, you've got so many different things that are happening within your organisation and within the public that it's very difficult to actually see that in the kind of short term, and it has to be based more on the kind of trends. Now, if we continue to deliver against that, we need to see how has that scored against some of the kind of key projects that we've taken forward. So I would have said we're seeing some positive steps. We're doing some really positive work with our third sector, with our carers and with social services, and I think it's a real positive move forward in terms of our steps towards integration as well, because it's starting to make us think in terms of that joint budget. How do we maximise the output in terms of the output that we want for patients or clients, rather than thinking about where the resource actually comes from? So the move to integration is now starting to mean that we're having very different discussions. But I would hope maybe within the next kind of couple of years we'll have more kind of concrete returns.
While you're answering, could you tell us how much of your budget that you're actually investing in these sort of initiatives?
I'm just going to finish off.
Percentage-wise?
Yeah, I mean, we were looking at it in the Change Fund, so we're looking at about £10 million over a kind of 3-year quantum. But again, that's just the Change Fund element. The real beauty is about how do you change services, and then how do you move the resources that come behind that. So whether that be our £250 million that we've got as a kind of baseline budget, or how much comes from social services in terms of their £70 million. So that's the real change that we're trying to make.
The reason we asked the question, I think, is to we're looking for a measurement, and we see that shift in budget because people are complaining to this committee in previous evidence sessions. Well, we don't see a shift in the budget. We see the local authority and the National Health Service or the board playing about with money here, but we do not see a significant shift in commitment to that preventative spend. So that's why I asked for an indication of the percentage of your budget. Might not. Anyway, carry on, please, Mr. O'Brien.
Yeah, thank you. I think lots of the work that we're doing in Orkney at the moment, and have done probably over the last 6 months, year, is round about our bed modelling for a new hospital. We said in our return we did, we're experiencing exactly the same demographic challenges as the rest of Scotland is facing, with their older population rising year on year. But what we're planning for at the moment, and what our numbers are telling is that we can survive on the same bed numbers in 5 years' time as we've got at the moment. And but that's twofold. That's actually what we're looking to do at the moment, is we're making a shift in how our medical services are actually provided at the moment. We're making the shift from a GP-led model within the hospital to a consultant physician-led model. So we're looking at changes in medical practice actually having an impact in our length of stay, and if you actually take us at the moment, a move to the Scottish average length in stay will actually impact by about 1,800 to 2,000 bed days in Orkney alone. In the context of 47 beds, that's actually tremendously significant. Where we're actually looking at the preventative side coming into it is we do have, depending on what measure we're using, Orkney is the highest age. I've got it down here. The European age standardised rate of hospital admissions for alcohol related in Europe. So the preventative agenda in Orkney in relation to alcohol is massive, and we've really got to be starting to, if we can really tap into that and get into the preventative agenda as it relates to alcohol in Orkney. But luckily we don't have a significant drugs issue, but what we do have is an alcohol issue in Orkney, and the number of alcohol-related admissions are quite phenomenal when you look at the charts comparing us with the rest of Scotland, where you look at the charts and you think there must be a mistake, but there's not. So that's where we're really targeted our resources, which is why what I was talking about earlier, where we've actually targeted some of our initial work in terms of probably a more focused commissioning piece of work in relation to our alcohol and drugs partnership. So our preventative spend, we're probably not spending probably much more, if you take all the child smell, the child healthy weight and all that, the preventative stuff's probably not touching much more than £1 million out of our £40 million that we might spend across the board. It's a discussion we're constantly having at the board as to how do we manage to move the money about. One of the things we're looking for to come out of our integration work that we're doing is we do have one of the highest resource transfer arrangements across Scotland, and we're looking for the integrated partnership now to actually start looking at and see if they can move the money which has been traditionally tied up in beds and day services. And what we're actually saying is, well, if you can look at that and redesign that and move that about within the partnership, we're more than happy. But we doesn't necessarily need to come back to us to go back out again. We're more than happy for that money to stay in the partnership. But that's £2 million there, which is to come into the equation, which is tied up in very traditional services at the moment. So that's really where our preventative agenda has been. We've been looking at that. We've been looking at, I think, the change in our medical model. We've recently employed 2 new consultant physicians. We've taken on board a local consultant obstetrician and gynaecologist. These are all having an impact on what we can do locally on the island. What they'll importantly, probably just a significant bit for committee members to understand in relation to Orkney. We only do general services within the island. Everything else then goes, 90% of it then goes down to Aberdeen. So we can have, it's really then trying to get into how much we can actually say, then not transfer to Aberdeen. And I know if Alan Gray from Aberdeen was sitting here at the moment, he's saying don't assume that then means you will save some money. But that's, so we've in terms of financial planning, we have, similar to Craig, we've not factored in any financial consequences of the preventative spend yet, where we're looking to take it forward at the moment. And does it allow us to live within the same bed numbers and actually have a footprint for a new hospital and their community services that are sustainable within what we have there? I think taking it forward, we'd be doing a lot of work with the board in terms of now how do we actually now use the preventative agenda and the population health agenda to take forward what services we're currently providing and should continue to provide in the future.
I think if I can just add around the one I would focus on is our local alcohol and drug partnership. I think the important thing to stress was that it's about improving the quality of life and the quality of health outcome for the individuals and the families and children concerned in that area. It's very successful locally around partnership working with local authorities, health and the voluntary sector. There are a range of schemes that have got very successful evaluation attached to them. I can't give you a breakdown to the actual amounts because there's maybe smaller schemes but with good outcomes. But I think I would stress the improvement in the quality of life there. I think over the time frame that we're talking about, we're not going to see cash savings, etc. out of that because we're going to have to continue. That's going to be a constant thing about focusing on families, etc. with challenges. So we need to keep that level of spend going. But what it will do in the future, some of the changes will help us meet some of the demand that's going to come through that we know from demographic change, etc. So it's not going to release cash, but it's going to help us be able to be sustainable in the longer term.
If it would help the committee, I could give you an example of one of the benefits of the preventative spend, and that would be in terms of smoking cessation. We've seen an increase in the number of quits in the most deprived SIMD, because we talked earlier on about equalities, increase of 40% in the number of quits. And speaking yesterday to the Director of Public Health, so I'm not responsible for this number, but she reckons that there's a cost of under £1,000 per QALY in relation to the quits that we're talking about here. So there is a significant payback. I think that's probably one of the most extreme ones, if I'm fair, but there's an example.
Thanks very much. That's been very helpful. But
it tempts us, though, because we get to a focus and a description. What with the alcohol and drugs, which is ring-fence money and earmarked money, and it's countable and whatever. The politicians are starting to get emboldened here. In terms of the smoking initiative, it was a parliamentary initiative responding to failure there, and the change funds that have all created a bit of action. Now, I suppose the question is, should we be encouraging more of this targeted approach in money, or the alternative is if you were getting that money that derives from this and getting a free hand and flexibility, would you use it in these areas? Yes, Mr. Martin.
I'll be brave enough to kick this one off. I mean, I was fortunate enough to be at the committee last year, and we talked about bundles and allocations that we got in terms of bundles. And we'd said last year there was a greater flexibility in terms of us now having, rather than having 18 different allocations within one bundle that all had to deliver different specialisms. We were given greater flexibility in terms of how we utilise that resource, in terms of delivering the outputs. From a financial perspective, we would always want that degree of flexibility in terms of how we deliver the outputs. So I suppose from where I sit, greater flexibility in terms of where the money comes to us, but clarity in terms of how you want those outputs, or what outputs are actually wanted to be delivered. Because you can understand, turning around and saying we've got to have a left-hand specialist in something within specific areas maybe isn't the correct way for us to go forward. Maybe an articulation in terms of what you want that output to be, and for more flexibility in terms of how that budget can be moved to deliver that output would certainly be helpful. And that's what we've got in terms of the bundling allocations.
I suppose, I'll not prolong it, we are on the time anyway, we've got another session, but in terms of prescribing and these other, change, preventative, the alcohol, they are pretty focused, and you've got to be accountable for them, and you are measuring at some point the outcomes. But, that doesn't apply to the bulk of what you're doing. Is the same scrutiny applied to what's being delivered in our hospitals every day in terms of the outcomes? The big bit, we don't, this is a periphery. The big bit, do we evaluate, monitor all of the procedures that take place in terms of their value? I mean, some of these things are beginning to be asked now in terms of should we be applying the same sort of scrutiny to the services we provide in our hospitals every day as we apply to this prescription of end-of-life drugs? Or
if I can perhaps pick that one up first. Certainly locally, we've got a performance management framework which is built on a balanced scorecard across the quality pillars that we use. So it covers efficiency, it covers effectiveness, it covers a patient-centred focus, it covers quality initiatives. We've got that at a strategic level at a board so we can see the indicators, and it's developing all the time as you add things in. We're now cascading that through our individual management units, which covers hospital services. It also covers the community, primary health care, it covers mental health, but have a balanced scorecard for each of the units so you can start to pick up and evaluate the outcomes, see where you need to change and flex within the organisation.
But is it as tough as the scrutiny that's applied to new medicines?
I think it'll be.
If not, why not?
I think these things will evolve and be built on, but we're working through a range of the indicators. There is tough challenge around certain ones of them. If there were ones that certainly were in the red category, we'd be challenging locally, and our challenge locally.
No one else, Mr. James.
I'm happy to give you a comment, but I think with respect, Convener, you should ask your question of the medical directors, because I think your question is really about clinical quality, and I'm reluctant to go into that territory, but I would say that obviously we through the patient safety programme, there's been a massive impetus to measure the negative aspects, that harm done and those sorts of things, and there's regular reporting on that. In terms of actually the quality of, how do you know one hip operation from another, and was that one better than another? I'm not qualified to comment, but I think you could correctly ask your question of the medical directors.
Okay. Oh, Nanette, sorry.
Just a small point. It's in answer to Drew Smith, I think, Mr. Marriage, it was you who mentioned discussion between boards to do with drug formulae. How much discussion actually takes place between health boards on formulary make-up? And is there any attempt amongst boards to sort of achieve alignment across the boards of formularies?
Again, that's probably something that happens more at your director of pharmacy type relationship, but they have strong networks where they sit down and have these discussions. And I know even that some of the formularies are shared between individual boards.
That's helpful, thank you.
Okay, just picking up Craig's point there, we use the Grampian formulary, we don't have one of our own, so we use the Grampian.
Okay, I don't think I've got any other questions, but can I, give my appreciation to your attendance, the evidence you've provided, the patience that you've displayed, and thank you all very much for being with us this morning. Thank you. We'll suspend at this point where we... We now continue on agenda item number 5 and move to our second panel of today. And can I welcome Robert Stuart, Director of Finance and Technology, NHS-24, Caroline Lamb, Director of Finance and Corporate Resource, Deputy Chief Executive, NHS Education for Scotland, and Julie Carter, Director of Finance, National Waiting Times Centre. Thank you all for being here with us this morning. I'm going to go straight to questions. Can I have Bob Doris, please?
Oh, right, Convener, I hadn't realised I was
nope, that's okay.
asking the first question. So, unprepared, I'll ask a kind of stock question, if you like, which is one of the things I see within my briefing, that the territorial boards are seeking to make 3% efficiency savings, which they can then seek to reinvest. Can I ask if whether your institutions are under the same targets, and whether or not that's a process you go through and how that would be reinvested?
First, so we are absolutely under the same kind of targets. We are constantly striving to obviously improve our services. The way we do that is looking at efficiency savings, and that money is directly invested into our services. And through the Golden Jubilee Hospital, we have made savings in excess of £2 to £3 million each year for the last couple of years. So yes, we're under the same level.
Mr. Stuart?
Yes, just to confirm that NHS-24 were also subject to that same efficiency savings target, 3% per annum. It's important to remember that that funding is retained within the board and reinvested. And we have continued to meet our efficiency target and take that forward. This year we plan to achieve higher than 3%. We're looking at somewhere around about 4.5%, which will be reinvested in patient care. But the answer is yes.
Okay, NHS Education, we're actually in a slightly different position in that the savings that we have to make are actually taken off our revenue resource limit. So we have suffered an actual budget reduction over the last 3 years now. Just to note as well, I think it's important that the committee understand that when you look at the figures that are quoted in the report around percentage levels of efficiency savings, the NHS Education saving looks very low at 0.8%, although it is £3 million. And I think it's probably helpful for the committee to understand what our budget is used for. The NHS Education budget supports professional clinicians in training. So we pay the basic salaries of doctors, dentists, clinical pharmacists, clinical psychologists, pharmacists, healthcare scientists while they're in training. And that occupies 63% of our budget spend. Now, those are trainees, so they're working towards being fully qualified professionals, but at the same time they are also providing services, so they are treating patients while they're in that period of their training. And as a result, that's not an area that we can target for efficiency savings at all. So we have to discount that, because if we were to make efficiency savings on that, that would reduce that workforce, it would reduce the trainees, and it would directly impact on the number of consultant doctors, for example, that we have coming through to take up consultant posts. On top of that, we spend a further 91 million on supporting the costs that NHS boards spend to support undergraduate medics in training. So I think when you look at our percentages, if you start to adjust some of those figures out, our actual, the 3 million, what the 3 million actually represents to us in money coming out of our budget represents about 6% rather than the 0.8 that it looks like on the surface.
That's very helpful. I wasn't aware, Ms Lamb, in relation to how efficiency savings worked within your area. I'm just kind of thinking that I fully appreciate why it's more difficult and more challenging to make efficiency savings given the model that you outlined before us. I suppose it also wouldn't be much of an incentive to make efficiency savings if it was then money lost to what you were doing. That's perhaps a debate for another day.
Well, absolutely. I think our position is that that's money that is directly supporting service in territorial health boards, and for us to make efficiency savings, not us delivering the saving, it would actually be directly impacting on what they need to deliver to patients.
I think that's a reasonable point. One, as a committee, we might explore, but I'm quite interested to get a flavour from your colleagues what kind of efficiency savings you have made. That would be quite helpful, I think.
schemes that we're looking at, a variety of things. I mean, looking at obviously scheduling of patients. We are primarily, a natural elective facility, so we've got the kind of fortune that we can plan maybe things a little bit, better. So we absolutely maximise that to make sure that we can improve patient outcomes, but we can schedule kind of better. So obviously the other areas, is actually around the kind of pricing and buying of things. Because we are a fairly small health board, we have a kind of centralised procurement function, so we can make sure that we are standardising things and getting our best overall, prices. So that's a flavour. I mean, obviously energy and all these other things that you'll see in other health boards we're also delivering, but that's kind of where we tend to focus
that's helpful.
our work.
Mr. Stuart?
Yes, we've tended to look at areas where we minimise an impact on frontline services. So we've looked at facilities, we've looked to share accommodation. The ambulance service have worked with NHS-24 to share accommodation both within our headquarter clinical area and in Norseman House. So we have some efficiency around that. We've recently reviewed our facilities management contract, which was previously taken forward by BT. We were able to tender that and made some fairly significant savings in that contract. We only operate in leased premises, therefore we have to have an FM facility to take that forward. We're also this year looking to share accommodation with Grampian Emergency Care Centre, so to move out of our quite expensive private rented accommodation at Riverside House and move into the emergency centre in Grampian, and that will generate savings, full year savings of around about £320,000. Also looking at other areas, carbon savings, unit cost savings in terms of salaries, etc. So a broad range of areas where we can meet our 3% and reinvest that in taking forward additional services.
Okay.
Yeah. Maybe to say, I've explained that that we as well seek to make sure that we're not targeting areas that would directly impact on frontline services and other boards. And a lot of our recent savings have been around properties. We've recently moved from 3 premises in Edinburgh, consolidating into 1, and we're now occupying about a third of the floor space that we occupied previously. That's been done through moving to no owned offices, which has been a little bit controversial, but it's actually working really well.
That's very helpful. Convener, thank you very much.
Yeah. What has the impact been on the organisations that you've tried to protect, frontline services, etc.? And in your case, in terms of doctors in training, has trying to protect the numbers there, has it slowed down the progress of doctors? We get from we get complaints about consultants and how quickly and how long it takes to get a consultant here as compared to somewhere else and whatever. Does that impact on any of that at all in terms of the progression rather than their training?
No, I don't think that the savings that we've made have been very much around looking at, I've mentioned facilities, but also looking at some of our back office functions and looking at, for example, as Julie's mentioned, looking at what we procure and how we go about that procurement processes. So I think I can safely say that none of that's had any impact on the length of time that it takes a doctor to progress through training, or on particular areas where it's more difficult to recruit doctors than others. I think that the length of time taken to progress through training is much more of a factor of more flexible working arrangements these days, feminisation and maternity leave and that sort of issue as well.
Yes, please. I'm looking for some risk factors, how you decide to cut. Somebody comes along and cuts,
I think probably one of the main risks working when you're looking for efficient savings is trying to avoid salami slicing and just chipping away at things. So I think it's really important, and certainly the approach we've taken is to look very carefully at where we spend our money, and a lot of that is around where we spend staff time and staff resource, and look to try and analyse that, to look to try and make sure that we're being as efficient and as effective as possible across all our areas of spend, and almost sort of take a step back and analyse what we're doing, and then get down into looking at where there are opportunities there for savings.
Yes, sorry, I was just going to add that we don't, we take a very kind of proactive view around savings. We look at the quality, and I can absolutely tell you that every saving we've made has actually improved patient, quality. We look at, that's really the focus we make. And I tend to sit in the kind of back seat on this, and I let the clinical people take all these things forward, and then I can come in and we start then talking about money. So we take a really, really kind of proactive view, and we've had fantastic engagement across all of our staff in our savings, and kind of hoping that that is going to keep going on.
I'd be tempted to be cheeky because all of the savings you've described are sensible. And I just, in terms of moving into one building and, and doing all of it, why didn't you do it before the cuts came? Why are you not doing that as a normal practice? And what are you doing now to ensure that you're going to continue to be efficient, or are you going to wait until another budget cut creates the opportunity for you to actually have that debate within your organisation and say, well, we need to have this debate because somebody's cut the budget, rather than how do we plan to be efficient? And
I think the programme isn't something that's just happened now. I mean, for example, within our headquarters, we actually share the building with the Greater Glasgow Finance Department. They occupy the top floor. That was taken forward 5 years ago because both organisers felt that was a way of managing the resource. The work we've done with the ambulance service happened a number of years ago again as well in Queensland. So it's an ongoing programme.
It's a poor understanding on my part, but I thought you had suggested that these were the efficiency savings that you had made as a result of the question to my vice convener in terms of the cuts and standstills in budget. But anyway, it's a poor understanding on my part.
I don't think I mentioned cuts and standstills.
No, you never mentioned cuts. That's a political difference.
So they couldn't have been answering that question if I never asked it.
I'm sorry, but when my vice convener was mentioning efficiencies, I thought that I misunderstood when you had told us that moving in, using joint chair and care was a result of the efficiencies currently, not 5 years ago. Frankly, I'm not interested in what happened 5 years ago at the committee today. I'm anxious to hear about how you're dealing with a situation as it presents itself. Anyone else? Yes.
I think because I referred specifically to moving from 3 buildings into 1, and we lease all our properties as well. So that was always in our strategy. It was about getting to the point where we were coming out of leases and managing to align those so that we could actually make the move into 1 property without it costing us more.
Nanette Millen and Drew Smith, thanks.
Mr. Stuart, I'm well aware, being from the northeast, of the new Grampian setup within the emergency care centre, and I think it seems tremendous that you will be there along with the ambulance service and with the GP call-out people. Do you see that as a model which, if transferred to other parts of Scotland, could act as a role model which would result in savings in other centres of NHS-24? Because it strikes me that to actually be co-located with clinicians is a very important aspect of potential savings and to patient benefit as well.
Yes, I mean, I think that's a very valid point, and we do see significant benefit in linking in with the clinicians in Grampian, but all of our local centres, we do link in with the out-of-hours services within those areas. And I think it's a model as we go forward that bears further scrutiny, because I think working with other clinicians, complementing what they do, whether it's out-of-hours, etc., is a key aspect of how we're taking forward the services we provide. Particularly as we now develop more services for boards in terms of branching out from just the out-of-hours overnight service we've historically provided, but into some of the other areas where we're supporting territorial boards in taking forward various clinical agendas. So,
it strikes me that the actual physical co-location is good, because you can then get much more informal relationships that probably work to patient benefit and don't cost any more.
Absolutely, and it's all about delivering better patient services and keeping the patient at the centre of our focus.
Usman.
Thank you, Convener. The Scottish health budget is falling in real terms, and people would probably naturally look to the, maybe not appropriately, but to the special boards in a different way from which they look to the territorial boards. I wonder if you could just take us, in, I think you mentioned it, where there was essentially a budget cut is applied to your organisation, and then it's your job to find the savings, which is a slightly different process from where it is elsewhere. What is the scale of unidentified savings within your organisations, and what do you see? Because it goes back to the convener's point, where are the opportunities coming from for those savings?
I think at the point that we submitted our local delivery plan, we were looking at about 800,000 of our savings as being unidentified at that point. But we have now got to a position where we've managed to identify all of those savings. Essentially, we're looking at areas like procurement, looking at making sure that we're maximising the use of national contracts, and also looking at how we buy goods. So looking at being as efficient as possible in our use of staff time doing that. And that, I think, then translates into what we're doing with looking at staff time in other areas and making sure that we are using our people as effectively as possible, because they're one of our most expensive resources. I've talked to you about the facilities savings that we're making, and we're looking at the rest of our estate and the opportunities for lease breaks across the estate to do something similar across all of that. And I think there are also, there are occasionally opportunities that present themselves. So we took on employment of all the GP STs, so that's doctors in training to become GPs while they're in their practice placements. We did that about 18 months ago, and as a result of that we were able to move from having to buy them individual professional indemnity insurance when they were working in practices to actually being able to bundle that together under one employer and under the totality of the NHS scheme, which saved about 600,000 per annum. So there are opportunities that present themselves, but I think it's, as Julie's described as well and Robert, that I think you have to be very proactive, that we spend a lot of time and energy looking at where there are the areas that we can do things better, because this isn't a situation that we expect to change overnight.
I mean, the problem is, though, that sounds like that's the job of directors of finances anyway. Yes. So could you take another 800,000 your organisation next year with no impact on anything that you do at the moment? You would need to divest from anything that you currently do. There'd be no.
No, I think that there will come a point where this becomes more and more difficult. We are really struggling. We plan on over a 3-year basis, and we're struggling at the moment to identify the savings that we anticipate we will have to make for 14-15.
Anyone else? Or?
Only just kind of briefly to add, we don't have any savings that we haven't earmarked for the next year coming. We've had really good engagement. We are kind of starting now, looking obviously at 14, 15, 15, 16 savings, and we spend a lot of time looking at innovation. IM&T services has changed dramatically over the last 5 years, and I'm sure it'll change over the next 5 years. And we are constantly looking at ways that we can obviously improve our services. And I don't have a feel in our organisation that we will reach a point in the near future that we can't come up with savings. There's always better ways that we can do things. And that is a key message that we play out within our board, and it's a key message that we get back from staff who are working at the coalface.
Mr. Stuart?
Yes, I think I've indicated that NHS-24 will move into Grampian. That will give us savings of between 320,000 and 325,000 per annum. The biggest element of saving going forward for us is the future programme, which was the reprocurement of our current applications and our infrastructure. We presented a business case that identifies significant savings on the current contract cost, and these were contracts that were entered into when NHS-24 was established 10 years ago. So the savings in terms of the infrastructure, which will be hosted by BT, the capital savings we'll make on the infrastructure that we will no longer require to manage or procure, and the integration of the applications, which currently range from a number of different suppliers into one via Capgemini, will deliver significant savings going forward. So our medium-term requirement in terms of savings, we've got a fairly clear idea of how that will be taken forward. but getting into years 4 and 5 of a financial plan, we're not quite there yet with those. We still have to do some work around that. But for the next 3 years, we feel we have an agreed way forward for our savings plan.
Yeah.
Maybe just also comment that I think we also all have to be cognizant of the pressures that we face to do different and additional things as well. And so for my organisation, that's particularly around doctor revalidation and managing that process, but also managing some of the educational requirements that may emerge out of that process as well. So, and I think, you know, that's why it's important to just keep a balance between the savings you can deliver and the things that you know you're going to have to deliver for the service and for the regulator as well.
So in terms of NES, when you say the point is 14-15, where you don't see that you would be able to continue just finding more of the savings like you're finding at the moment, the savings would then have to come from the training side, from actual how we facilitate and ensure the training of doctors.
I think that's not for me to make a decision on, because the numbers of doctors that we train is driven by workforce planning and is determined by the Scottish Government rather than for us. So the budget that I have is to train a set number of doctors, and we wouldn't look to amend that without there being a decision about us requiring less of those. So no, our position is absolutely that we will not look to take money out of the training grade establishment.
But then I'm confused, because if you say that there is a set number, and that makes sense, and we know how much that costs broadly, and we know that at this point in time, you're saying that you certainly find it very difficult to identify more savings from the other things that you can do, but you would expect that in 14, 15 and beyond that you would be continuing to be asked to make savings, then those two things don't add up, do they?
We're obviously going to have to, we need to carry on looking to see where there are more opportunities. I think what I'm trying to highlight is that it's very difficult to keep trying to generate savings when those savings come off your budget, and at the same time trying to manage the pressures that you've got to continue to respond to requirements from the regulator and others.
Thanks very much.
Is that a discussion that you've had with the Scottish Government in terms of?
Yes, it's a continuing discussion.
It's a continuing discussion?
Yes.
Okay. And in terms of the other aspect of it is about additional responsibilities, as well as the tight budget. If you could, maybe add to that about, the additional expectation of the organisation. But more positively as well, I mean, money doesn't always equal, I think we've maybe discovered that earlier, that there are moves that can be made to create savings. Money doesn't equal service development. So, but at this point, is it dominating the discussions within your organisations rather than rather than focusing on service development? Or is it driving that forward? Is the financial considerations dominating? Are there things that you would like to do in your service that could develop it, but you can't? Or
yeah, no, we don't. Sorry, just to come back to that, we don't. Absolutely, we are not seeing finance driving service change. What we're doing very much is seeing the actual clinical people driving service developments, innovation, service change. I'm there working closely with them, and I can pick up very quickly if that looks like we're going to see cash savings out of that. But that is absolutely what is driving our service. And I tend to sit with them, but slightly behind them, as they're kind of driving all of that forward.
But you're in a fortunate situation then that you're able to meet all of those demands of the clinicians and say, well, whatever you want, I can get you. Is that, you're meeting all the demands, are you?
We don't quite have that kind of blank check, but these people who are working with patients every day have got fantastic ideas, and they come to us. We have a very open way with them that they come to us and they come and say to me, look, if I use this valve, it might cost a little bit of extra money, but I could potentially save in ICU days, etc. I would then look at that, we set that up as a pilot, we make sure that is going to work, and then we deliver that. But it's very much these guys driving that, it isn't us.
Yeah, it relates to some of the issues in the questionnaire about what, if you had that bit of extra money, what would you do with it? Yeah. So there's nothing you would do, your perfectly happy, you know, good. You watch the next budget round.
I know, I wish I hadn't said that.
But any of the others want to engage in that?
It's important to recognise that we do retain the savings within the organisation. So we tend to use those savings to develop services. And within NHS-24, we've been very keen to see how, as an organisation, we can support territorial boards by using digital technology, either directly in terms of the work we do with some boards around patient reminder service, where we try and help them manage the DNA list, or in terms of musculoskeletal work we do there, you know, having a skill mix that can deal with that and support boards around that, and the wider use of digital technology in managing a sustainable health service going forward. Because I think you've heard this morning of some of the challenges around that, and I think with NHS-24 and the work we've done with the Scottish Government around the European agenda, there is a real opportunity to use digital technology to help manage the pressures, the demographic pressures, etc., will be taken forward. So we use our savings to help develop that investment and support other boards, and that includes the emergency dental service, smoke line, cancer helplines. And these areas can provide savings, not directly for us, but they can help territorial boards manage their resource in a different way.
Yeah. But I take it that's a difference, you know, key
yes,
with an efficiency.
Yes.
That you're not controlling, or a top slice. I'll not use that
no,
C word in case
that's right.
Upset anybody. But you know, the top slice is a bit different.
It's a bit different to genuine efficiency savings, which are then reinvested and taken
yes.
forward.
So you've got all of that to reinvest in
yes.
your service, both of you.
Yes.
Yeah. Ms. Lamb.
Yeah, thank you. I've flagged a couple of areas in the questionnaire where we recognise that there are going to be real demands for training and education and additional input into training and education in the future. One of those is around health and social care integration, where I think that, you know, in order to really get that working operationally and to and culturally as well, there's a real requirement for increased input in training and education. And I think we've done quite a lot of work around that, particularly the sort of things that don't cost a lot of extra money, like building partnerships. So we've been working very closely with the Scottish Social Services Council for the last 3 years now, and we have a memorandum of understanding with them and a joint action plan. And that's about really bringing together the resources and expertise from two organisations to start to identify where are the real areas that we're going to need to work together in future. We've also been looking at the infrastructure that we have built up for education in health and how that can be deployed more widely across the social services sector. So we've already launched, we have the Knowledge Network, which contains over 3,500 electronic journal subscriptions and e-books, and that's already been spread more widely so that that's now accessible by social care staff as well as by NHS staff. And those are the sort of things that you can actually make a difference without having to spend a huge amount of additional resource. Obviously, if there was funding available, there's a lot more that we would want to be able to do as well. And I think the second area is around healthcare support workers. And I was reading something yesterday about the healthcare support worker group, the sort of proportion of the NHS workforce that they represent. I think there's about over 60,000 staff there, and they tend to be a group that haven't had in the past a lot of access to very structured education and education that's transferable, because I think that's the importance about doing things nationally, that it means that if people move jobs, then they're not starting from scratch. Without, you know, they've got qualifications or accreditations that they can transfer, and I think that's a huge group as well. And those were the two areas that I'd listed on the question as the two things that we're talking about a lot in terms of what, you know, the way in which the health service is developing, the way in which we all want to see integration developing, and how we can help to make that happen.
For that, Bob.
My apologies for continue on efficiency savings. The reason for that is actually we are doing a budget scrutiny process, so there are lots of questions, you know, we'd like to ask about generally about what you do, but that's kind of not the purpose of today's evidence session. Now, Ms Lamb, I'm going to return to efficiency savings with your organisation shortly, but Can I just check for clarity, because before I was on the Health Committee, I was on the Local Government Communities Committee with our convener Duncan McNeill, and local authorities previously were not able to keep their efficiency savings. They were top sliced and they were lost to local government. I have no idea what the position was within the health service. Could you maybe tell me, Mr Stuart, Ms Carter, did you all, whenever you were asked to make efficiency savings, did you always keep them, or were they previously top sliced?
They've always been retained.
Yeah.
So that's a
that's
consistent
absolutely,
situation.
we have absolutely always kept them. Yeah.
For territorial boards, there was a clarification or a distinction between those boards that provide patient-facing services, similar to the Golden Jubilee and myself, as opposed to boards which didn't provide patient-facing services. So that's the only distinction. But we've always retained our savings.
That's really helpful, just for accuracy, so we've got that position. Ms Lamb, you mentioned you're in continued discussions with the Scottish Government over the cost pressures that the NHS education will face in the years ahead. I assume that's been an ongoing dialogue for a number of years. Is that something that normally happens, or have you specifically had to raise cost pressures? Is there always a weather eye kept on it, or is this something new?
Yeah, I mean, there's always a weather eye kept on it, and you know, we are in constant dialogue anyway. So it's not something that's specifically different. But I think a lot of it has been about just getting clarity around that budget breakdown, about how much of it is untouchable, if you like, and how much of it is the bit that we're focusing on. And I think from our perspective, it's very helpful to have the opportunity to talk to the committee about this, because from our perspective, when you look at the stark figures and you see sort of 0.8% as our savings, then that's a bit disappointing from our perspective, because that's not how it is, you know, in real life and on the ground. So I think it's important that both Scottish Government, yourselves, appreciate that's how the position actually stacks up, and that there are big areas of the budget that that for us to start to make savings on doesn't affect us particularly, but absolutely affects territorial boards and patients.
I think that's where I was kind of leading on to my next question. In terms of the funding formula, and I know there's budget rounds and budgets will be set, you mentioned, as we've heard at the Health Committee before, workforce planning tools and how that will have a direct impact on the amount of undergraduates that go into the system across our universities, not just for doctors but a variety of other clinical professions. Is there I'm not going to ask what the formula is, but is there depending on what comes out of the workforce planning tool, does that kickstart a formula in which part of it feeds into your budget allocation? So if there's an anticipation there's going to be a reconfiguration and, let's say, slightly more nurses, maybe considerably more GPs in 5 years' time, or 6 years' time, because that's the kind of, hopefully they're planning over the medium term, would that then have a direct impact on a kind of formula basis into your funding settlement?
I think probably the straight answer to that is no, because the budget isn't really driven on a formula basis. And I think that the other thing to understand is that the lead times between starting to recruit undergraduates, extra undergraduates, and them getting through medical school and then coming into our sphere of responsibility, let alone when they eventually end up at consultants, is a very long time. And that's why workforce planning is such a difficult thing and such a complex thing. So certainly, yes, we would see our budget adjusted if there was a decision made. So, for example, a few years back, as part of the Dental Action Plan, there was a decision made to up the intake into dental schools, and also then the Aberdeen Dental School was set up as well. And we would see that reflected in a change in the number of vocational training places that we're then expected to provide sort of at the appropriate time. But it's not, so it tends to be much more specific. So it's much more, there's been a change of X here, so that knocks on to needing more places of whatever variety there.
I suppose what we're trying to drive at, that's a very specific example you gave. Was there then a very specific budget line from the Scottish Government to yourself for that? I think that's what I'm trying to get to, is which part of your budget it's quite clear you must deliver X, and therefore via whatever formula or ring-fence budget line the Scottish Government gives you Y. And it's then how that's reported, because obviously if that's part of the overall cash sum that you talk about a percentage efficiency saving around, that's a kind of maybe a false comparison to make. So it's about getting, from my point of view, I'm not trying to put words in your mouth, it's about getting the accounting of that better. It's saying, well, look, X amount of the cash is directly towards very specific commitments that you don't do efficiency savings around, because there's a direct result, you want more X, therefore you give us Y. There is no efficiency saving around that, we just do it. And it's about efficiency savings around maybe back office stuff, or how you better manage all those kind of things, the bureaucracy around it all, that perhaps there can be efficiency savings around.
Yeah. Absolutely, and in practice that is absolutely the way in which it's treated. And I think what has been very helpful with Scottish Government is the dialogue that we've had with them that has been about making that separation, which is why I'm sure Scottish Government wouldn't have found it acceptable for us to be delivering less than 1% efficiency savings when you look at every other boards being an average of 3%. And that's why when you start to adjust all our budget numbers, our efficiency saving works out at a higher percentage, because we have had exactly those sort of discussions with Scottish Government, and there is that understanding about how those numbers break down. It just doesn't appear when you just look at the one budget number.
Well, hopefully this evidence session has allowed us as a committee to tease some of that out, so when we look at our briefings and do next year's budget scrutiny, perhaps we will not be looking at the global sum spent by yourselves, but we'll be looking at the efficiency savings based on part of your budget, which might be more helpful for the committee. But that's really informative. Thank you.
Thank you.
I don't think I've got much more questions here for you, but maybe you know, just as we asked earlier for earlier panel, what evaluation of the work you do, what outcomes that you get. I'm picking up a wee bit on you, Mr. Stuart, in terms of smoke lines and other things that we do, and we spend money on them. Are we confident that there are good outcomes there that we should be, that's something we should continue, and that ticks all the boxes, the equality box, and you know, all that?
Yes, I mean, absolutely. And if you look at, for example, the work we've done with some territorial boards around how we can help them manage their DNA, you know, the do not attend waiting list issues. There has been and there will be evaluation of those pilots, you know, from a health economics perspective, to understand that the investment we make in delivering that service, it creates to a benefit in terms of the wider health environment. So by helping boards manage their waiting times, then it does free up either those slots to be used more efficiently and effectively, or for them to reduce the number of waiting initiatives they need to take forward. So that's one example, and we do have a process whereby we will, with the boards, evaluate that. And of course, there's the wider issue around the whole digital technology agenda and the work we're doing with the Scottish Government in terms of telehealth care, and the wider European work, the funding we're having for a number of areas that we can take forward digital technology. And those will also be subject to rigorous review to ensure they do deliver towards our 2020 vision, our quality agenda, and provide value for money for the health service in Scotland.
I mean, I can see some of that in terms of the do not attend. I was thinking more about, you know, if you want to quit smoking, you're phoning, phone a helpline or whatever. At the same time, we're arguing that very locally that should be delivered at the pharmacy at the end of your street or in your supermarket or whatever. Are the outcomes good in these sort of these helplines, and is it something?
Yes, I wouldn't be able to give you a definitive clinical answer to that, convener. I mean, with Smokeline, what we are taking forward is an NHS smoke line, as opposed to what we have at the moment, which is a commercial smoke line. So there's an economic saving in using the technology we have to deliver that service. The benefit of that, I think, will be demonstrated within boards, but I couldn't give you an answer to that. Intuitively, I would say there is a benefit to that.
Yeah. The wider question, I don't know how to apply it to the others in terms of that, but what I'm asking is, that aspect of your work, is it evaluated, is it monitored, In terms of what we've discussed here this morning about what we cut and what we don't cut, and you know, here a service.
Yes, I mean,
is it evaluated? Are there good outcomes? Is it worth continuing with that, or can someone phone another smoke line or go into their pharmacy? Why are we all doing it? I suppose is the question.
They are evaluated. Some of it will be done by NHS-24. Some of it will be done by the health boards if we were doing work with them on it. So the health boards would evaluate the benefit of the service we provide.
You hope they're evaluating it?
Well, yes.
You're not.
we hope they're evaluating. They are under significant pressure to make sure they do manage their resources in the best possible way. So anything we can do as a national board to help that, I think they would welcome.
Yeah. The broader question is, are we carrying out services that are evaluated, are worthwhile, and are we reviewing any of those?
Yeah. No, for us, it's absolutely yes. Yeah. We have quality dashboards in every single ward in the hospital. We know the outcomes for everything we do in the hospital. We have patient satisfaction. We have all of that is absolutely monitored, and we look at that on a daily basis practically, and also that flags up if there are areas that are starting to waver that we can look to see, is that something we need to invest money in, or is that something we need to look at on an efficiency basis, and we look at that daily practically. So and absolutely.
It's used as an important tool to direct your decision making and your budgetary process, and it's all taken into account. It's an important aspect.
Yes.
It's not just there.
Yes.
But you're actually using it as a tool.
Absolutely using it as a tool.
Is there anything similar in the other organisation?
Yeah, I mean, for the largest part of our business, which is the most expensive part, which is around training doctors, then the evaluation is effectively whether we're meeting the General Medical Council standards and whether we're training good doctors, but there's also a lot of other work that we do around developing educational interventions, and yes, we carry out evaluations for all of those, and we will take that into account in deciding whether we've gone around something the right way, whether the way in which we've delivered the education was appropriate, whether we've hit the right targets. I mean, I think it's challenging, and I think the panel earlier talked about it's challenging sometimes to pin down a result to just one factor, and education I think is particularly challenging because there are so many other things that impact, as well as how somebody's been trained and educated. But yes, we do evaluate all of our educational interventions.
Yes, and we have performance dashboards where appropriate. We have our LDP targets, and we also discuss with boards how the service is being provided. So, for example, with our MSK service for Lothian, where we try and triage patients who require physiotherapy, we do determine the impact of that on their clinic. So there is work with boards around the performance standards and how we take that forward. So it's a very key part of what we do within NHS-24 and as a special board.
I don't think I've got any other questions, have I? No. Can I thank you all for your attendance here today and the evidence provided? Thank you very much indeed. Thank you. As previously agreed, we are now going into private session. Thank you.